much delay, let us start our academic journey for today with a deep dive into basic sciences and radiology, setting the stage for understanding liver cancers from a molecular and diagnostic lens. I welcome our opening speaker, Dr. Ragini Rajashekar, Associate Consultant at APCC. She's trained oncopathologist with expertise in cancer diagnostics and a keen interest in molecular pathology. Dr. Ragini has received multiple national awards for her research and contributions to cancer pathology.
Thank you, everyone. Good morning. So my topic is on from risk to response, predicting early metastasis in hepatocellular carcinoma and diagnostic insights from PD-L1. It's mainly regarding the understanding of aggression, identifying the risks, and guiding responses. Hepatocellular carcinoma is the 6th most common cancer and the 3rd leading cause of cancer death globally. Despite many advancements, outcomes remain poor, especially for those with early metastatic spread. HCC is biologically heterogeneous and some behave indolently, while others show early aggressive progression. The focus is mainly in understanding early metastasis, risk, and PD-L1's role in the diagnostics. So why do some hepatocellular carcinomas behave badly? We have seen that not all tumors behave according to their cancer stage or their cancer size. Some small tumors metastasize very early and others remain localized for years. This reflects an underlying biology difference, not always visible on routine imaging. Early identification is a critical to modify the management in these cases, and so this behavior is directly linked with the molecular drivers for aggressive HCC. So what are the molecular drivers of aggressive HCC? TP53 mutation, TERT mutations, beta-catenin pathway, and stem cell-like features. So TP53 mutation is common in aggressive HCC, and it is mainly associated with poor differentiation and genomic instability, resulting in immortalization of cancer cells. TERT promoter mutations enable limitless replication and hence is a hallmark of a cancer progression. Beta-catenin pathway in turn contributes to Wnt signaling pathway and it activates the stem cell-like features. The most important thing is like stem cell-like features can be identified by expression of CK19 and EpCAM1. So CK19 is a very simple IHC marker, and when it is positive, it indicates that the tumor behaves aggressively, and which can be routinely practiced in all the biopsy samples of hepatocellular carcinoma to rule out the aggressive behavior. So the mechanism of early metastasis, it can be either via epithelial mesenchymal transition, angiogenesis and vascular invasion, microenvironment's role, and immunologic escape mechanism. EMT is nothing but EMT enables the tumor cells to acquire the sarcomatous property and lose its epithelial property. And then this in turn results in detachment of tumor cells and early vascular invasion. Neoangiogenesis supports both growth and also for dissemination, and this is usually via VEGF, and this can be targeted with targeted antibodies. The tumor microenvironment, we all know about PD-L1, which will be explained in detail later. So what are the clinical predictors of high-risk HCC? Poor differentiation in histology, microvascular invasion, elevated AFP levels of more than 400 nanogram per ml, infiltrating pattern, and lack of tumor capsule in radiology imaging. So this is a H&E. This is a H&E image showing, this is a moderately differentiated area where we can still make out the cords and trabeculae of the liver cells. And this is a poorly differentiated area which is cells are arranged in predominant non-descript sheets. There is no pattern of arrangement, and they are highly pleomorphic cells with increased mitotic activity. And this is an image showing the microvascular invasion. These are the lymphatic channels, and the tumor cells are in the lymphatic channels. And in microvascular invasion, there are other factors like what is the level of vessel involvement when there is more than 5 vessel involvement, or when there are more tumor cells in the vessel, the number of tumor cell clusters in the vessel, and the distance of the MVI from the actual capsule. All these results in a more aggressive behavior of the tumor. So PDL1 is programmed death ligand 1. It is mainly expressed by the tumor cells to inhibit the T cell mediated destruction. So tumor cells usually exhibit a PDL1 ligand, which in turn inhibits the activation of immune cells. So when we give the antibodies, like targeted immunotherapy, it in turn binds with the T cell PDL1 antibodies, and hence it results in the it unmasks the expression of PDL1 from the tumor cells, and hence results in the destruction of the tumor cells. So PDL1 expression is a marker of aggression. It correlates with poor differentiation. Early microvascular invasion can be also identified, early metastasis, and this detection is mainly via immunohistochemistry, and there is emerging research for liquid biopsies. The next one. So the clinical implications for in surgery, when the PDL1 is high, despite a curative resection, there is a high chance that the patient will have metastasis when the PDL1 is very high. And for oncologists, the guide consideration, like you will be giving a immunotherapy, and particularly atezolizumab or bevacizumab. And PDL1 also helps to stratify small but aggressive hepatocellular carcinomas, and hence it impacts the surgical planning, surveillance intensity, and the systemic therapy timing. So the future is in integrating the molecular markers, the imaging, the radiology features, and liquid biopsy, which is an ongoing research for early prediction, risk prediction. And PDL1 is a routine biomarker. Is it really a routine biomarker is still a debate. We currently use only when there's systemic disease, it is being done. Thank you. Take-home message. Not all small hepatocellular carcinomas are biologically indolent. Early metastases are driven by molecular and immune factors. PDL1 holds a diagnostic and a therapeutic relevance. Multi-disciplinary approach is essential for the risk and adaptive management. So in managing advanced liver cancer, it should be a team approach where science, surveillance, and team strength is essential. Thank you.
Thank you, Dr. Ragini, for those insights into metastatic markers and PDL1 diagnostics. Now we welcome Dr. Alec Correa, consultant medical geneticist at APCC. He has a rich background in clinical genetics, academia, and diagnostics. He has done his MD medical genetics from AIIMS, Delhi. He is passionate about applying genomics in clinical oncology, and he has published several papers in reputed national and international journals. Stage is yours, sir.
Good morning, everyone. Today, the title of my topic will be Unraveling the Germline Genetic Associations with Hepatobiliary Cancers, Insights and Implications. So, in current literature, there's lack of data regarding the germline implications in hepatobiliary cancers. Currently, germline testing is not recommended as part of any standard guidelines for hepatobiliary cancers. However, it has been seen that studies which have looked at testing patients who do not meet any of the guidelines often pick up germline variants. And it's been seen that 50% of patients with pathogenic or likely pathogenic germline variants might not meet any of the established guidelines as of now. So there is a potential for missing a lot of patients who possibly have an underlying germline mutation. So when we are looking at genetic risk, this can be categorized into different categories. So there are some genes which are high-risk genes. These are, for example, like BRCA1, BRCA2, TP53. These are relatively rare in the population, but the risk involved is quite high. So a patient might have between 70 to 90% risk of developing lifetime cancers. Then we have a moderate risk genes. These are genes which convey a risk of about 30 to 50%, and these are also relatively rare in the population. And finally, we have the common variants. These are the polymorphisms which are common in the population. So these only convey an incremental small risk to a person who carries them. So there have been a number of studies looking at the influence of genetic polymorphisms on the risk for hepatobiliary cancers. Certain mutations in genes such as TM6SF2 and PNPLA3 have been well established. However, most of these studies have either come from Western literature or East Asian literature, and the kind of incremental risk which they lead to is just small. And often these studies are limited to certain populations, and so it is not really translatable to the Indian context. Now there's increasing studies looking at polygenic risk scores. That is, they combined a number of these polymorphisms in order to try to calculate a risk score. However, as of now, it has not reached the evidence level to be incorporated into clinical practice for hepatobiliary cancer. However, recent studies have tried to combine both the rare genetic variants with these polymorphic variants and tried to show that these might be useful in predicting the development of cancer. In the last 4 to 5 years, there have been a number of studies which have looked at the incidence of hereditary cancer syndromes, that is, these rare hereditary cancer syndromes in the population of hepatobiliary cancers. So a number of studies in the last 4 to 5 years have looked at that, and surprisingly, a lot of them have found that the incidence has been between 10 to 15% of the population of these patients carry a pathogenic or likely pathogenic variant in one of the hereditary cancer genes. This is a significant burden because earlier it was thought that in hepatobiliary cancers, this genetic risk would have been low in view of the large, since most of them are caused due to environmental influences. And this percentage of 10 to 15% in fact rivals that of breast cancers and pancreatic cancers, where genetic testing guidelines are well established. So a prospective multi-center study had looked at around 200 patients, and they found that 15% carried this pathogenic variants in hereditary cancer genes, out of which a significant percent had mutations in high and moderate risk genes. And they showed that 75% of these patients with these pathogenic variants would have been missed if we had only followed the present NCCN guidelines. So that would be a significant burden missed, and 82% of the patients with these variants had variants in genes where it was clinically actionable. That is, there could have been a change in management either with some targeted therapies or in the future surveillance. Similarly, another study, this is from Korea, they found that 16% of the population had variants in DNA damage, had germline variants in DNA damaging genes, out of which 50% of those patients had variants in the homologous recombinant genes, that is the BRCA1, BRCA2 and similar genes. They showed that patients with these pathogenic variants in the homologous recombinant genes had a poorer prognosis compared to patients without this, and they also did some cell line studies, and they had demonstrated that patients with these germline variants in the BRCA2 gene may be susceptible to PARP inhibitors. So they showed that there was possibly detecting these patients might help in the treatments. Finally, there are some rare genetic syndromes. These also carry these syndromes generally are treated by geneticists. These are monogenic disorders which affect the liver, and they carry a high risk of developing hepatocellular carcinomas. So when a patient is sent for a genetic evaluation, I'll just briefly outline the kind of pathway they follow. So first is we decide who should undergo genetic testing. As of now, there's no society has given any guidelines for who should undergo genetic testing for hepatobiliary cancers. But generally, we would see if there's a positive family history, if there's abnormal age of onset of the cancer, if a patient has a history of another cancer previously, and often now, through tumor board discussions or through somatic testings, we help identify patients who possibly will be at risk and then refer them for genetic testing. So once a patient is referred, we do a pedigree analysis. So we try to look at a spectrum of cancers in the family to help narrow down what genetic syndrome we could be dealing with. We look for any other clinical clues. We look at colonoscopy or radiology reports, and also the pathology thing. And if somatic testing is done, we try to look at those results as well. Then we decide what kind of genetic test to be done. Most commonly, we send a gene panel, which we send like a comprehensive cancer gene panel, which covers most of the common high and moderate risk cancer, hereditary cancer genes. However, at times we may broaden the thing to an exome or a genome sequencing. And finally, there's interpretation of reports. This can be sometimes challenging because there are different categories for the variants. Benign, likely benign, most labs will not report. So labs will report variants of unknown significance, likely pathogenic and pathogenic. So if a patient has a likely pathogenic or pathogenic variant, then we can take clinically actionable steps. We can act upon it. However, often we get variants of unknown significance, so that can be a challenging in interpreting. We look at that on a case-to-case basis, and we recheck the classification, and then we decide whether we need to act upon it or not. And if not, then we ask them to come for reclassification on an annual basis, and it's been seen that 80% of these get reclassified either as likely benign or benign, and 20% get up classified into likely pathogenic or pathogenic. So finally, just looking at the utility of germline genetic testing, it helps diagnose the underlying hereditary cancer syndrome. This is important to help prognosticate the patient. There might be some therapeutic implications such as PARP inhibitors or immunotherapy for like Lynch syndrome. These patients will be counseled about their future cancer risk, and we put on cancer surveillance and offer risk reduction measures. And finally, genetic counseling for the other family members. We offer cascade testing to other at-risk members, and then if anyone is planning pregnancies, then we can offer pre-implantation and prenatal genetic diagnosis. So just some common, to give an example of common hereditary cancer genes such as BRCA1, BRCA2, treatment implication would be, might be possibly they could be treated with PARP inhibitors. Then risk reduction surgeries would be a bilateral mastectomy or bilateral salpingo-oophorectomy, and we would put them on surveillance. Similarly, for Lynch syndrome, there might be an use of immune checkpoint inhibitors. There is evidence for using aspirin to reduce the risk of colon cancer and reduce starch to reduce the risk for extracolonic cancers. And there's screening for upper GI, lower GI, urothelial cancers, and pancreatic and endometrial cancers. And leaframani, currently there's no treatment there's no treatment changes which could be made for it. But there is risk reduction measures in the form of bilateral mastectomy, and then screening for breast, brain, soft tissue, and upper GI and lower GI cancers. So in conclusion, hepatobiliary cancers may carry an unrecognized burden of hereditary cancer syndromes. Expanding genetic testing will help pick up these patients. There's currently lack of data in the Indian context, so it would be important for us to test to see what the Indian data is. And incorporation of germline testing in the treatment of these patients will help improve the understanding of the disease. There might be application of precision therapies, and also allow us to test other family members and offer cancer preventive strategies. Thank you.
Fascinating takeaways on genetic insights. Thank you, Dr. Korea. Now let's move to the clinical dimensions of HCC. Please welcome Dr. Aditya Shah, consultant medical gastroenterologist at APCC since 4 years. He's trained in advanced therapeutic endoscopy and is attached to the liver transplant team at Manipal Hospitals, Bangalore for 4 years prior to joining APCC. Dr. Aditya Shah will explore the impact of etiology and liver functions on multidisciplinary care.
Hi everyone, good morning. First of all, I would like to congratulate everyone for the launch of the ALCC today. I have been asked to talk on hepatocellular carcinoma, impact of etiology and liver functions in multidisciplinary approach. HCC is amongst the most commonest causes of mortality amongst patients with chronic liver disease. It is responsible for almost around 8 lakh deaths globally in a year. It is usually there is a male preponderance at the ratio of around 4:1. In the adults, it's around the 5th most common, in adult males, it's usually the 5th most common cause of cancer, whereas in females, it is 9th most common. Overall, it is the 6th most common cause of cancer in males and females put together. In the Indian scenario, as per the ICMR guidelines, means the ICMR research, the incidence amongst male ranges from 0.7 to 7.5 for women and 0.2 to 2.2 per lakh amongst males. The median age for presentation of HCC is around 40 to 70 years, and it increases with the age. And as the age increases, the frequency of liver cancer increases. Most of the patients of HCC usually have an underlying chronic liver disease, and we have to find the reason for the chronic liver disease in order to find the further treatment. The commonest risk factors include chronic hepatitis B, chronic hepatitis C, which may further lead to progression into cirrhosis. The other causes of cirrhosis, which include non-alcoholic fatty liver disease, Wilson's disease, autoimmune hepatitis, alcohol consumptions are also the risk factors for patients who land up with HCC on progression. The other inherited causes include ataxia telangiectasia, hypercitrullinemia. There are patients who are females who have increased use of oral contraceptive pills also have a risk of developing hepatocellular carcinoma. The other liver conditions also include patients who have alpha antitrypsin deficiency as well, and Wilson's disease as an underlying cause. Patients with hepatitis B, C, alcohol, autoimmune hepatitis, and cirrhosis due to any other reasons as well are high risk for developing hepatocellular carcinoma, whereas patients with primary biliary cirrhosis have a low risk. Patients with hereditary tyrosinemia are at a high risk of developing HCC. Coming to the incidence, patients in Central Europe usually have alcohol consumption as the most common cause of developing HCC, whereas patients in Central Latin America and East Asia usually have hepatitis B and hepatitis C as the common causes of further progressing into hepatocellular carcinoma. HCC and cirrhosis. Cirrhosis is usually one of the commonest risk factors which further develops into HCC. As discussed, 60 to 80% of the patients of HCC further have underlying cirrhosis. Usually, it is a prerequisite for HCC, and we have to confirm the cirrhosis using invasive and non-invasive modalities. Etiopathology, there are usually two ways. It's a cirrhotic pathway and a non-cirrhotic pathway. Cirrhotic pathway is present in patients with hepatitis B, hepatitis C, alcoholic liver disease, and autoimmune hepatitis. Patients with hepatitis B and hepatitis C also have a non-cirrhotic pathway as well. All patients with hepatitis B and C it's not necessary that they have an underlying CLD in order to develop HCC in future. Non-cirrhotic pathway is also present in NASH, aflatoxin-induced, and metabolic diseases. How does the progression happen? Patients usually with a normal liver further develop having chronic hepatitis changes at around 6 months' time, which further develops into cirrhosis at around 10 to 40 years. These cirrhotic patients may develop nodules or hyperplasia, dysplasia, further leading to malignant transformation at around 20 to 40 years. Hence, we have this age where it's around 40 to 70 years where these patients develop HCC. In patients with hepatitis B, they can develop even in absence of cirrhosis. 70 to 90% of the patients who develop will have cirrhosis. It usually depends on the viral load of the patients. Patients with higher viral load who have not underwent treatment for hepatitis B tend to develop hepatocellular carcinoma. Genotype C and D of the hepatitis B are associated with high risk of developing HCC. Risk of HCC is not only related to the hepatitis B exposure, but they can also be associated with chronic infection. Patients who have underlying diabetes, who have underlying infections with HDV are more prone to developing HCC as compared to the normal person. These infections usually are acquired during birth, that is vertical transmission from mother to the fetus, mother to the child, or early childhood are at a high risk of developing HCC. Hence, we actually propagate to use vaccinations during the childbirth. How does this progress? Acute infection, most of the times it has undergone seroconversion, and these patients don't develop into chronic hepatitis B. But those patients who develop into chronic hepatitis B will require treatment. Like nowadays we have entecavir, tenofovir, alphenamide for hepatitis B. But there are patients who are even on treatment with antivirals have developed hepatocellular carcinoma. So it usually just helps in prolonging the disease, and these patients will actually develop cirrhosis in future and may further progress to liver cancer, may require liver transplant in future. Similarly, in the case of hepatitis C as well, most of the patients are usually have developed hepatitis C during blood transfusions in the 80s to 90s, when we were not doing enough blood checks before transfusions. In view of this, we actually find a lot of patients who are undiagnosed with hepatitis C nowadays, and when we do a routine blood checkup, we find that they are positive for hepatitis C, and we need to treat them with antivirals. Which patients are usually at a high risk of developing, which patients with hepatitis B and C are usually at a high risk of developing hepatocellular carcinoma? They include patients who are more than 50 years, male patients who already have a family history of hepatocellular carcinoma, who have underlying cirrhosis, obese patients, a larger HBV DNA load, co-infections, diabetes, who have diabetes and increased liver iron load. How can we prevent HCC in patients with viral hepatitis? Vaccinate the children on birth, and early treatment with antivirals for hepatitis B and hepatitis C. Chronic alcohol use and aflatoxin are also known to cause patients have an increased risk of developing HCC, and when the patients who are alcoholic plus who consume plus who are hepatitis B and hepatitis C positive, there is a synergistic effect, and they are at a higher risk of developing HCC. Other risk factors include nitrites, exposure to hydrocarbons, solvents, pesticides, increased metabolic liver disease such as hereditary hemochromatosis, alpha-1 antitrypsin deficiency, and Wilson's disease. Females who are taking OC pills and anabolic steroids are also at an increased risk. How do we confirm, means when do we find out that the patients have HCC? Means when the patients come with complaints of abdominal pain, mostly that is a frequency of 59 to 95%, weight loss, weakness, abdominal swelling, non-specific GI symptoms, and yellowish discoloration of eyes. The signs include hepatomegaly, ascites, which is distension of abdomen, where we need to actually check the fluid cytology as well to rule out if there is the ascitic fluid is not consisting of malignant cells. Jaundice, hepatic bruit, and wasting of muscles. Extrahepatic metastases are present in patients where lung is the most common, intra-abdominal lymph nodes, bone mets, followed by adrenal glands, and brain mets, which is a rare thing. Paraneoplastic syndromes associated with HCC include carcinoid syndrome, hypercalcemia, hypertension, hypertrophic osteoarthropathy, hypoglycemia, neuropathy, osteoporosis, and these also. How do we work up a patient when we think that the patient is having hepatocellular carcinoma? We have to do a routine blood test, liver function test, prothrombin time, rule out portal hypertension, For ruling out portal hypertension, we actually also have to screen the varices of the patient. If the patient has large varices, we may have to band the varices also in order to prevent GI bleed in future. If there is an underlying hepatitis B and C, we have to treat for the same. Comorbidities of type 2 diabetes, mellitus, and hypertension also need to be ruled out, and whether there are any metastasis or vascular involvement. Diagnosis include non-invasive methods and invasive methods, biopsy, which will, and for the non-invasive methods, serological markers like AFP and PIVCA, and imaging markers where I think CT scan, MRI, which would be discussed later on. For patients who have, for patients with HCC, when we have to do the liver function test, we do the bilirubin, AST, ALT levels, kidney function test, and prothrombin time. The bilirubin levels are usually unconjugated hyperbilirubinemia and conjugated. For conjugated is in patients with HCC, we usually have a conjugated hyperbilirubinemia, and we actually need to rule out any obstructive pattern also. So that also usually has a conjugated hyperbilirubinemia. But in order to distinguish whether it is an obstructive pattern or intrahepatic cholestasis pattern, we actually see the ALT and the AST levels and alkaline phosphatase as well. When patients with ALT and AST, which is usually more than 3 times the normal, we actually think it's more of acute hepatitis. And in those patients, ALP levels are usually less than 2 times. In patients where ALT, AST levels are less than 3 times, but ALP levels is higher than 2 times, it's more of a cholestatic disease, where if albumin is normal, we consider it to be an acute cholestasis, and where albumin is low, we consider it to be a chronic cholestasis. In order to differentiate between extrahepatic cholestasis and intrahepatic cholestasis, the GGTP levels are higher in patients with intrahepatic cholestasis, whereas GGTP levels are lower in extrahepatic cholestasis. The scoring pattern for patients with cirrhosis, we use 2 scoring patterns, which is Child-Pugh score and a MELD score. Child-Pugh score consists of bilirubin, serum albumin, INR, ascites, and hepatic encephalopathy, where A is from 5 to 6, B is from 7 to 9, and C is from 10 to 15. It is a simple method. It involves clinical parameters. The disadvantage is that it does not have portal hypertension, which we consider, and the clinical data is quite subjective. Patients with child A are usually compensated cirrhosis, and child B and C are usually decompensated cirrhosis. MELD score, it is more for predicting the death for patients, how they are going to respond to the further treatment. Its advantages, it includes renal function and prioritize liver transplant. Higher the value, better to do the transplant as early as possible. Coming to the serum markers, alpha-fetoprotein is the commonest serum marker which we usually do, but it's not necessary that all patients who have, there are patients with HCC who even have low serum alpha-fetoprotein, and hence, in order to confirm that, we need a liver biopsy. AFP is not specific to HCC. It is also other cancers like testicular cancer, germ cell tumor, and gastric cancer may at times have AFP which is elevated. It can be high even in patients with viral hepatitis. PIVCA is another serum marker which we do for patients. The specificity and sensitivity and specificity is around 48% and 81% respectively. In patients with HCC, usually the values are around 100 to plus or minus 78, whereas in a healthy person it's around 0.79. Which patients require a screening for HCC? All the patients who are at a high risk for HCC usually should undergo screening regularly. They include patients who have underlying cirrhosis, which may be patients who have hepatitis B, C, have alcohol consumptions regularly, then hematochromatosis, autoimmune hepatitis, NASH-related hepatitis, primary biliary cirrhosis, and alpha-1 antitrypsin deficiency. Even patients without cirrhosis but who have hepatitis B and C and non-alcoholic steatohepatitis should undergo regular screening for HCC. The take-home message: all patients with chronic liver disease should be regularly screened for HCC. Early diagnosis is always beneficial and has a better prognosis. Patients with chronic viral hepatitis should be treated with antivirals. Avoid the risk factors which can worsen the liver. Thank you. So it's the same thing only, sir, but NASH doesn't only include alcohol. MASH includes alcohol also. There are patients with alcohol and who have a metabolic like obesity and everything, they go into MASH. For NASH, it is only without alcohol. No, sir, it's both the same, sir. It is just modified now into MASH because NASH did not have alcohol, means we used to have non-alcoholic steatohepatitis. But in MASH patients, we include alcohol and obesity. If they are both together, we included them in MASH category.
We hardly hear of this term. So
no, it's now a modified term. We hardly use NASH now, we use MASH. Yes, sir.
Thank you, Dr. Shah, for highlighting patient-centric liver care. To complement that, we now turn to imaging, where clarity saves lives. Dr. Arnan Murali, Senior Consultant and Head Radiology at Apollo Proton Cancer Centre, with over 18 years of experience and subspecialized interest in GI oncology imaging, will now walk us through the role of MRI in diagnosis and treatment responses.
How do you go back? Very good morning, and a bit more technical now. Now, HCC is one of the end results from chronic liver disease. Okay, so, but HCC is not the only end result. Okay, so our role here is to find what are the pathologies that occur in a cirrhotic liver. Now, if HCC was the only end results, imaging becomes very straightforward. And we say, okay, fine, a lesion comes up, pops up during screening, and therefore it is HCC. But you see that there are also non-malignant lesions, malignant lesions other than HCC, which occur in patients with chronic liver disease, like cirrhosis. Now, in any such scenario or any complex situations, it's always nice to have a pathway wherein we say, okay, fine, if it goes towards this direction, you do this, or you do that. And there are multiple paths. You know, if there are, again, it's not a single disease, single entity. There are multiple paths. And for this, there are been many programs all around, you know, based on the continents. Many pathways have been tried, tested. But one thing which is gaining traction now is something called LI-RADS. It's liver imaging, radiology, and data system, reporting and data system. So this is developed by the American College of Radiology in association with the American Association for Liver Disease. So this is something which is gaining traction, but of course there are other strategic pathways, but which I think going forward, which will be more popular, is something called the LI-RADS. Now, I want to use this platform to sensitize people and to, you know, maybe brief a little bit more about LI-RADS. Now, LI-RADS has two components. One, we use it in the diagnostic pathway, or we can use it after the diagnosis, that is after treatment. So there are two things, LI-RADS for diagnosis, LI-RADS for treatment assessment. So let us first see what the LI-RADS pathway, I'll say this as a pathway for in diagnosis. Now, we use this in patients with chronic liver disease. You know, we cannot apply this in a healthy liver. Now again, first is where you can use this is it in patients with chronic liver disease. And chronic liver disease, not from vascular causes like Budd-Chiari, and also not in patients younger than 18 years. Okay, this is our target population of whom we can apply this paradigm to. Now, what is the goal? Now, there are different radiologists use different terminologies. not always accurate. You know, you can mean something, it may get translated into something else to the clinician. Now this is has been formulated so that there is an uniform language, and wherein if it comes A, then you do B, then you do C. That is the whole aim of this LI-RADS pathway exercise. Now what we do in LI-RADS is we classify it, or we risk stratify the lesions as, you know, in 5 or 6 categories. What we are interested is in LI-RADS 5 and LI-RADS M. That is it either a HCC or a malignant lesion, but not HCC. But then, you know, it's not always straightforward. You know, we have criteria wherein we say, okay, fine, you know, you have point A, point B, point 3, therefore it falls under LI-RADS 5. If there is A, B, it may fall under LI-RADS malignant lesion. So we'll just briefly touch upon how we stratify each lesion. So a bit into radiology, I'm not going to go into images, but there are 5 major criteria that we use. One is, when we are stratifying patients, it is very necessary that we do an MRI or a CT, preferably an MRI, and with contrast. We do a contrast-enhanced MRI or a contrast-enhanced CT, okay, and it's done in a dynamic phase. So then, based on those findings, we stratify them. So there are 5 main things which we look at. One is the enhancement, that is how much it is vascular it is, you know, enhancement pattern. And once it enhances, it gets washed out in the delayed phases. So we look at the washout. And there are other findings like the capsule, which we'll see in the later stages. And one of the main important things is the growth, or the threshold growth. Now, let's say you are not sure in the initial scan, then you ask the patient to come up, follow up another 6 months, and then if it grows more than 50%, then we bump it up and we say this is more likely to be HCC. There are major factors, then there are also minor factors or ancillary factors, which once you put them as LR3 or 4, you can use these small findings to bump them up or bump them down. You know, so once you are not very, very sure, you can use these ancillary findings to either change the diagnosis as +1 or -1. Okay. This is a classic example wherein you see a lesion which is enhancing, that is the middle image, which shows that it is enhancing with contrast, and in the delayed image, you can see that it is washing out with a nice capsule around it. This is a classical LR5 lesion, which is a malignant lesion. It is definitely a HCC. This is very nice if we get such an image, but not often we get such images. What happens is that lesions don't fall under these 5 categories. I said, you know, arterial phase enhancement, washout with a capsule. You can see that some lesions, the first image, it can enhance, but it will not wash out. Some lesions will not enhance, and therefore you cannot talk about washout also. Whereas some lesions have a very, very heterogeneous appearance. It doesn't fit under a HCC, but you know definitely that it is malignant. So what do you do in such cases? There are 3 options always. Either you follow up, you treat, or you biopsy. So this LI-RADS, what it does is, it will stratify the lesion into either of the categories, LR1 to LR5 or LRM, and then tells you what to do. If it is a lesion in LR3, that is, it is likely benign, then you follow it up in 3 to 6 months. If it is LR4, either you do a shorter follow-up in 3 months, or you discuss in the MDT and you go in for a biopsy. If it is LR5, mostly nowadays they say that once it is LR5, you can go ahead with treatment. But then, you know, you also have lesions which come as LRM, that is the malignant lesion, but not necessarily HCC. In those cases, again, you have to go in and biopsy it. This is to highlight why we need a risk stratification. You know, the left are all the terms which can be found in reports. Okay, you can say consistent with HCC, could represent, may represent, likely represents. But if you actually translate it into clinical practice, you will see that it's like a scattergun approach. You will see the lesions falling under all categories. So I think this is, I want to highlight why we need a proper pathway wherein you risk stratify it and standardize it so that all clinicians are using the same language. But not all LR5 lesions are HCCs alone. There is a small percentage that although they are LR5, 3 to 2% that they are not HCCs. Again, LR3 we say mostly benign. But again, even that you can see there is a 38% chance of it being an HCC still, and also a 40% chance that it is still a malignant lesion. Whereas LR4, again, not all LR4s need to be or progress to HCCs, it can also be benign. So there is a very granular pattern here, but why? This is because that not all HCCs are uniform and unique. There is a varied pattern which occurs at multiple levels. One, it is at the pathway levels, at the immunohistochemistry level, and also at the gene levels. So this contributes to the heterogeneity of the HCCs. Again, because of this varied tumor biology, we have different appearances. Again, to stress that imaging is nothing but a partial replication of the tumor biology. I will not say exact, but a partial replication of the tumor biology. And this is what is causing the confusion, that it is not giving us the confidence to say that this is definitely LR5. You can have a few hits and misses along the way. A lesion may appear as LR3, which is likely benign, but it may turn out to be malignant in the end. Again, of all the HCCs, if you take, only 52 to 73% of all HCCs will behave in the LR5 pattern. That is, the LI-RADS pattern is like the likely or most likely to be HCCs. You can even have around 11 to 25 patients which behave in the LRM pattern. They can be non-HCC pattern but malignant, but it will still on a HP come back as a HCC. Again, 2 to 23% of HCCs will have a LR3, which is the most likely benign pattern. In each LR category, you can see the varied appearance of the occurrence of various histopathologies in each LRs. So again, because of the variations in tumor biology, we have to accept that it is not foolproof, and an LR5 lesion or LR4 lesion can be benign, an LR3 lesion can be malignant. Again, studies have shown that following up lesions over time, let's say an LR3 lesion, can turn into LR4, that becomes thing, or after a few 6 months, it can get bumped down to LR2. And similarly, LR4 lesions, you may label that as a LR4. LR4 means likely malignancy, likely HCC. 6 months down the line, you know that it is a benign lesion. So there is a small, let's say, confusion which does exist. Again, studies have shown that there are a percentage of lesions in LR3 which are malignant. Some remain stable. Now, what do? You still follow it up. Again, for all lesions, there are 3 things. Either you follow up, biopsy, or you treat. So this is with the diagnosis part. Now, I'd like to apply LI-RADS also for the treatment part. This is something which has gained traction over the last 3 or 4 years. It's called the LI-RADS treatment assessment. Now, there are 2 ways of looking at treatment assessment. One is at the local level, or one is at the whole patient level. We use RECIST at the patient level. You say progressive disease, stuff like that, at the patient level. That is modified RECIST. Or we can use LI-RADS when you're looking at the tumor level. When I say when you use LI-RADS treatment, it does not look at patient response, but rather at tumor response. Again, it's similar to LI-RADS. We use, again, the patient population here is patients treated with local treatment. What are the local treatments? Not the systemic treatment, with either ablation, okay, either RFAs or microwave ablation, or it can be with TACE or TARE, and also with radiation therapy or radiotherapy, SBRT, proton. What are we looking at here? Once you treat the lesion, you follow up that lesion alone. You take into account and you label it based on that lesion alone. You either say treatment, the tumor is fully killed, or you say there is still viable tissue within it. That is our only concern. Dead tissue, still living tissue. So how do you go about it? Again, even in this, there are two cores. When you come to local treatment, there are two things. Either you can use burning techniques, or ablative techniques like RFA, microwave, or you can use TACE. For that, it is a different core or a different paradigm. Sometimes for patients who undergo radiotherapy, TARE and radiotherapy, you use a different paradigm. The terminology we use, again, what is necessary is to look at viable, but in patients who undergo ablative procedures and TACE, if you're not sure, you say it as equivocal. Whereas on the other core, with radiation, you will not say equivocal, but you will say non-progressing. We'll just give examples of that going on. The concept in patients who undergo ablative procedure, it is that you are killing cells immediately. That is, as soon as you burn the tissue, the cells die. So therefore, that is the concept we use here. And you say, once you give the treatment, the cell should die immediately. Okay? And you label this as either LI-RADS non-viable, equivocal, and viable. Only three. This is an example of the top row. You see a lesion which is enhancing. Microwave ablation. After 6 months to 3 months, there is no enhancement. So therefore, there's nothing viable. One thing which you can also see to enhance our diagnostic confidence is something called the coagulative necrosis. In a T1, the lesion appears bright, so we can call it is totally necrosed. But whereas if you see a lesion with a nodular enhancement even after treatment, let's say 3 months to 1 month after treatment, you will label this as viable tissue. Okay? That is the only thing. This is for patients who undergo ablative procedures. So what do you do? In patients who are, if you are non-viable, yes, you can leave it, maybe follow it up at 3 months or 6 months, or even not follow it up. But if it's viable, you're sure you have to go retreat again. Okay, you can go retreat, not you should. You can go retreat again. But if it is equivocal, we can't say, somebody comes and asks you what to do. You say, he's there in that room, I don't know. You have to tell him, okay, fine, he may be in that room. If he's not in that room, do this. So if it is a thing, again, you follow it up either in 3 months' time. The other thing with radiation therapy is that you take off the term equivocal and you introduce the term non-progressing. It's because the treatment response is not immediate. It happens over time. Okay, so here, instead of equivocal, you say non-viable, non-progressing, and viable tissue. An example, here you can see a lesion in segment 5. After treatment, this is 1 month after treatment, you can see that there is still some enhancing lesion at the periphery, and you can see that there's some diffusion restriction. You will say this as it is not increased in size. The lesion is not increased in size, and also there are no, new enhancing foci within it. So this will be a non-progressing lesion. The bottom row, you can see that after treatment, the lesion has slightly decreased in size, but over time you can see that over 2 years' time, you can see that it is completely gone. So this, again, it's a non-progressing lesion, and then it becomes a non-viable tumor. So again, for radiation therapy, you have to wait 6 months to up to 2 years. If you see new enhancing lesions in a tumor, then it raises an alarm, then you say it is as a progressing or viable tumor. So just to summarize, the whole concept of LI-RADS is to have a clear pathway wherein you say, okay, fine, if it comes as this, then you go in this pathway, and it gives a bit of clarity. There's the language becomes unambiguous, becomes very uniform, and say, okay, fine, everybody is in the same page. So LI-RADS is a bit of a standardization practice or a standardization exercise. I think going forward, like how BI-RADS has caught on in the breast, it is the standard now. BI-RADS is the standard. I think going forward, LI-RADS will be the standard in treatment of HCC and focal liver lesions. Thank you.
For want of time, we request the Q&A session to be taken in person during breaks. Let us move on to our next track. Moving from diagnostics to cutting-edge treatments, I welcome Dr. Jaikant, consultant in charge, PET-CT, nuclear medicine and theranostics, over 14 years of experience with special interest in theranostics.
Good morning, everyone. So I am here to talk about TARE. It's called trans-arterial radioembolization. In the management of HCC, where it takes its place in the management algorithm of HCC, especially in the era of established clinical benefits of TARE with regard to overall survival and response, it is being largely masked by TACE, which is basically because of one thing is lack of awareness and lack of infrastructure. That's what I would put it as. So let's go through things. So I'll base my talk first. We'll see where TARE stands in the recent guidelines compared to what it was initially, what are the pragmatic indications going forward, and some evidence-based dose optimization, personalized dosimetry to deliver, where we were asked by conventional radiotherapy, where we are asked what is the dose you deliver. So we have gone forward in that strategy also, and we'll see some cases and end up with future perspectives. So if you see the BCLC staging, the management guidelines of BCL staging initially published, if you see the various stages, you can see the early stage, nowhere TARE was there. It was basically ablation wherever possible, resection and transplant. And then if you see the intermediate stage, that's when predominantly it is dominated by TACE here. TACE takes the predominant role here, and advanced stage there is literally no role, no mention. The only place where it was mentioned was when the exceptional scenario where you have a larger single lesion up to 8 centimeters, you can go to TARE instead of TACE. It was in 2022. Later, there are very good randomized clinical trials published. You can see the two major trials which established the role of TARE, the PREMIER trial and the TRACE trial. You can see the median time to progression basically was 26 months versus 6 months when you compare TARE versus conventional TACE. This was published with PREMIER trial, and if you see the TRACE trial, it is also a prospective open label randomized trial which compared TACE versus DEP-TACE. So here also you see you get a longer time to tumor progression than DEP-TACE, 17 versus 9 months, almost a double. So the median overall survival was also 30 months compared to 15 months, and the study was terminated. So such is the benefit of TARE in the era of DEP-TACE, which is predominantly known to everyone as the best targeted loco-regional therapy. Taking that into account, you can see the INASL modification, Indian Association, National Association of Liver. So they revised it, and they took, you can see here, the modification in the intermediate stage group. Now TARE has almost, it was incorporated and almost replaced TACE in the intermediate stage group, especially BCLC B group, B1, B2, see child PUA up to B7. B7 is the cutoff for considering TARE. So before considering any systemic therapy, in such cases, there are various scenarios, especially when the disease is infiltrative, diffuse, extensive bilevel involvement. TARE has a very good role, which is when the picture looks like this, automatically the patient goes in for systemic therapy. Otherwise, this is a common strategy followed, but definitely TARE can possible, but not in all patients, in carefully selected patients, especially and those with macrovascular invasion, locally advanced disease with portal vein invasion. TARE has a very good response rate and survival advantage. The main thing here is it can downstage the patient, it can do stage migration, which we'll see. The patient who are initially inoperable or not a candidate for transplants, TARE has converted them to transplant candidates and those for surgical resection with curative intent. So coming to pragmatic indications in current real world scenario, you can consider various scenarios, various intent from curative to palliative intent. So if you have a patient who is surgically not fit for surgery and not fit for ablation or a smaller lesion, so when you have a larger lesion up to 5 centimeters, you can do TARE with a curative intent. So, and when you come to a neoadjuvant setting to downstage a patients, especially when you have aggressive angry tumors in PET with high FDG, sorry. So when you have a neoadjuvant setting, when you want to downstage the, when you want to use it as a neoadjuvant setting with high AFP, even though the tumor is localized, but that the AFP levels are high, PIVKA levels are very high, very FDG avid, intensely FDG avid tumor, infiltrative type, you can use this as a neoadjuvant setting to downstage the patient and to potentially consider for a curative intent treatment. And then mainly in current day scenario, when many patients want to undergo liver transplant, so when they are initially not fit for a candidate for liver transplant, TARE can be used to downstage the patient, and also to give a longer time. Now it's not the patient have to wait a long time for getting a liver for transplant. So the tumor can progress in the long waiting time. So this time to tumor progression has been significantly delayed by TARE rather than TACE. So that is a very big advantage of TARE compared to TACE. So it acts as a bridging for a liver transplant. Then later on in the palliative setting or when the disease is locally advanced with the macrovascular invasion, again you can use TARE along with the SBRT for lesions with and reduce the, you can retract the portal vein and you can even recanalize the portal vein which was involved along with systemic therapy. And also in the palliative intent, when the tumor burden is very high, you can reduce the tumor burden and give a better quality of life. Though overall survival is not going to change, you can even give a better quality of life with when you incorporate TARE into the multidisciplinary setting along with the SBRT and systemic therapy. So these are the pragmatic indications. So just to give a gist of what happens in a TARE, what are the different things. When the patient comes, we do a proper thorough workup. We do initially see for fitness. Now CECT has been almost replaced by FDG, basically to stage the patient to rule out a surprise extrahepatic MET. And we also see for the tumor biology. We should make sure the patient is child A or the cutoff is child B7. And other things, kidney functions, ECOG performance status. Then we proceed to tumor mapping. So we do basically a visceral mapping angiography. We need to assess the splanchnic and mesenteric vasculature. So that things are done. If there are any entry collaterals, that has to be embolized. If the tumor, we see the volume of the perfused tumor territory, then identify the site of planned MAR Y90 delivery. Nowadays, this cone beam CT has also been incorporated it is in the cath lab. Now we do that just to make sure we don't miss out on any inadvertent arterial feeders which are missed by conventional angio. And then proceed with the technetium MAR shunt. So this MAR scintigraphy is basically to assess for the lung shunt fraction. So you know HCCs, they have a higher tendency to have arteriovenous shunting, skipping the tumor capillary bed. So we need to know how much is going to the lungs to avoid inadvertent radiation pneumonitis. So, and also we look for the distribution of particle in the tumor, whether it is heterogeneous or homogeneous, whether we need to re-stratify the target vessel, the target artery injection, and then finally dosimetry. So this is where we also, once we have a technetium map, we can calculate how much dose preferentially goes into the tumor, into the normal liver. We have the total liver volume, total tumor volume. So we can calculate how much dose exactly have to be injected to achieve a particular radiation dose. So conventionally it is a minimum of 120 gray which is delivered. So we accordingly, there are formulas to calculate how much dose has to be injected optimally to achieve that dose. So once you do all the workup, once you do the mapping, we order and then treat. So on the treatment day, the labs are repeated to make sure the patient is not deteriorated, replicate the angiogram, and then do the dose delivery. So this is the typical setup which we through which it is injected. It is the activity is here, and it is injected by as the interventional radiologist will put the catheter into the tumor vessel, the target vessel. Nowadays it is very super selective injection. So once that is done, we inject it based on our initial dosimetry approach plan. So the optimal planning is the key here. A multidisciplinary discussion and followed by optimal planning is the key. The aim is to optimize and maximize the tumor dose. It's a minimum of 120 gray, but not necessarily. So depending on the tumor volume, we can increase the dose up to 400 gray for a radiation segmentectomy. So at the same time, protect the liver and protect the normal liver. So the patient should not deteriorate because of radiation hepatitis. So coming to dosimetry models, initially it all started with a simple body surface area model where we don't do any personalized dosimetry. It's a standard dose based on the body surface area and the percentage of tumor involvement in the liver. For example, if it is more than 50% involvement, we inject 3 GBq of dose, considering that 3 GBq delivers 120 gray. But later on, we move on to MARD model. This is especially for a solitary lesion involving a segment where you need not bother about the tumor to normal liver ratio. So we inject, we follow the MARD model. Now, these are become obsolete. Now we are moving more and more into a personalized dosimetry approach by the partition model here, where practically we can calculate how much dose we want to give to a particular tumor. Suppose for in case of a radiation segmentectomy, we gave up to 400 grays to the tumor. And then now the latest is the still personalized is the voxel-based dosimetry, where even finer, smaller lesions can be targeted with a particular radiation. So these are the various papers we will see which have established the clinical overall advantage of TARE and demonstrated the improved survival due to TARE. So the basic thing is that when the absorbed dose to the tumor is increased, it increased the mean overall survival. So you can see here, this is the study where resin-based microspheres, when you deliver a mean dose of at least 250 gray to the tumor, it had prolonged the overall survival by like 33 versus 16 months when it was less than 250 gray. So when the mean dose is still increased, then it is then you can achieve almost a complete response here. So this is one of the main trial which established that dosisphere study. When you do a personalized dosimetry approach, delivering the optimal dose you have that it is delivered, you can increase the you can downstage the patients even in those patients with portal vein thrombosis. Almost 44% of patients, even with a locally advanced disease, can be downstage to a surgical candidate. And these are the other studies which showed that those patients who undergone curative surgeries and transplants after TARE, the impact on the overall survival. Here, this dosisphere study showed that the overall survival has not reached even after 6 years of follow-up. Whereas this legacy study, you can see the patients who underwent a transplant after TARE, the overall survival rate at 3 years was 93%, which is very, very, very significant. So this is a very important slide. This is how, these are the various scenarios we face in our clinic, and this clearly shows the different clinical scenarios, the clinical scenario and the clinical intent we want to treat. If you see, if the clinical scenario is just a single lesion confined to a single segment, then we aim for a curative intent treatment by doing a radiation segmentectomy. So we try to deliver at least 250 gray to the involved segment. So we calculate the dose and deliver accordingly. So similarly, when you have a larger lesion, when you want to treat an entire lobe, we aim for radiation lobectomy, and here also the intent is potentially curative. So what we aim to achieve is deliver at least 250 gray to the entire lobe, 250 gray to the tumor, and 40 to 70 gray to the normal lobe, with the fact that it might be able to hypertrophy the contralateral lobe. So we just aim for that and see the test of time how it behaves. So if there is a good hypertrophy of the contralateral lobe, it can go in for a curative resection later on. So, and this is the common scenario which we face in our setup. So tumors are usually multifocal or bilobar. So these are palliative intent treatments. So when you have a multifocal unilobar disease, then the minimum dose we aim is at least 250 gray to the tumor, but we reduce the non-tumor liver dose to 40 to 70 gray, because we are not aiming for a contralateral lobe hypertrophy. We don't want the normal liver. We want to preserve as much as liver as possible. And when you have multifocal bilobar disease, we do a sequential targeting. So we first target the lobe with the high tumor burden, and then later on, when there is a response or a stable disease, we can target the other lobe. So let's see some few cases. This is a patient with a solitary large tumor in segment 6-7 and few tiny lesions in the other segment. So after discussion, it was decided to go for a radiation segmentectomy with TARE along with the SBRT for the tumor thrombus. So the planned dose was around 250 to 300 gray to the tumor and to the non-tumor, with the hope that it will induce hypertrophy of the non-involved lobe. So here, this is how the planning angiogram is done, the tumor mapping is done. This is the technetium mass scan. This is how we inject and then see for the lung shunting, whether it is properly localized, whether there are any extrahepatic deposition of the tracer. So once that is all done, then patient taken to the cath lab, and this is the post-treatment SPECT and PET-CT. So we can do Bremsstrahl lung imaging. It's called Bremsstrahl lung imaging. Yttrium emits this Bremsstrahl lung. You can image it and then again confirm that post-treatment. So this is the baseline. You can see the nice tumor arterial enhancement. Then 3 months, you can see the almost 80% necrosis happening. This is 6 months. You can see a complete necrosis happening. And the portal vein thrombus was treated with SBRT, and you can see the enhancement completely going off after SBRT. So the baseline to 6 months, you can see a complete tumor response here. So this patient, since it was a single lesion, no other thing, otherwise good compensated liver, no other risk factors, patient was transplanted. Stage migration is the real key here. You give the test of time for the tumor biology to show up. If it is a good tumor biology, you can even turn a patient into a curative intent treatment, curative patient. So the key is selecting the correct patient using the appropriate targeting and then implementing it. So this is another patient which is child A patient with a huge tumor involving almost the entire right lobe here. So planning angiograms were done, tumor feeding vessels were marked, then mass scan was done. Again, aiming for a lobectomy, segmented radiation lobectomy at dose of 300 gray was planned. So again, you can see a nice deposition of yttrium in the tumor and involving almost the entire right lobe here. So these are the baseline scan. 2 months, you can see partial necrosis. It's a huge tumor, 18 centimeter tumor. You can see a partial necrosis. 4 months, there is further response. As Dr. Arnan was saying, you wait, you give it responds over time. The radiation takes its time to show the response. So this patient from baseline through 10 months follow-up, you can see a nice response. But unfortunately, this patient didn't have a contralateral lobe hypertrophy. So there was no, he didn't go for a curative resection. The disease control was achieved and he is on follow-up. So this is what I was telling about voxel-based dosimetry. We can very precisely calculate how much dose we want to deliver, activity we want to deliver by say drawing the RY, how much dose is getting concentrated that, what is the volume of the tumor. So we have this software which is FDA approved, so we can give pinpoint radiation. So this is another setting where a patient with sigmoid colon carcinoma with hepatic metastasis. Here, no other disease, liver predominant hepatic metastasis. So TARE was given. Post TARE, there was a complete response. So patient underwent a palliative sigmoidectomy, and later on, after 15 months, there was recurrence in a different area. So we were able to give a hepatic progression-free survival of more than 10 months in this advanced stage. So coming to the future perfect, where does it go? So TARE is a part of a multimodality treatment, especially when you consider stage migration. You need TARE is very helpful. And the immunomodulation properties of TARE, now a lot of immunotherapy has come into the systemic therapy setting. So combination therapy with checkpoint inhibitors and TKI benefits when you do it with TARE. And then personalized dosimetry is the way to go. We optimize and maximize the tumor dose to get the best response. And nowadays it is done with super selective infusion points. We go to till the distal most part of the artery where we can deliver, so that we can avoid radiation going to the normal liver. And then nowadays radial artery access is used, which in fact instead of a femoral artery approach, it helps in immediate mobilization and doing it as a day care procedure. And there are also potential new indications are being tried outside the liver. So this is where TARE is progressing to. Thank you.
Thank you, Dr. Jaikant. Now joining us is Dr. Mukta Mahajan, Lead Consultant Interventional Radiology and Breast Radiology at APCC, trained in vascular and interventional radiology with over 14 years of experience. Dr. Mukta will guide us through the therapeutic and supportive potential of minimally invasive procedures.
Hi, good morning, everybody. Yeah. So I'm going to be talking on redefining liver cancer care, the role of interventional oncology in advanced liver cancer clinic. Interventional oncology is no longer an adjunct treatment, but it forms a core pillar of liver-directed therapies in HCCs, primary liver tumors as well as metastatic liver tumors. So why an advanced clinic? We know that there is rising incidence of HCC and liver metastases globally. These cancers require complex care and also coordination across multidisciplinary teams. The vision of this clinic is to have one-stop referral, work up the patient and treat the patient as a team and not as an individual. We know that the patients most of the patients complain about fragmented care when it comes to different aspects of their treatment, whether it's through medical oncology, gastroenterology, surgical oncology, radiation oncology, as well as interventional oncology. Not to forget pathology's contribution and nuclear medicine's contribution. So it's very important to bring all these subspecialties under one roof and treat the patient with a common intent of either palliation or cure right from the beginning. When it comes to interventional procedures, there are multiple liver and biliary procedures, including vascular, percutaneous, transhepatic biliary interventions. But today's focus is going to be on interventional oncological therapeutic procedures such as transarterial embolization, which includes bland embolization, chemoembolization, as well as the selective internal radiation therapy, which Jaikant has already covered. I will also focus the attention on tumor ablation, which includes thermal as well as non-thermal modalities. The thermal ablations, the commonest known to us is RFA, which has the longest evidence available, and the microwave ablation as well. The new kid on the block is cryoablation, and one of the advanced ablation techniques, irreversible electroponation, is also gaining momentum. So when we talk about therapeutic and supportive procedures of interventional oncology, there are four main headings when it comes to liver-directed therapy. The arterial therapies, yes, but apart from that, it's very important to also include the resection enablers, which means that the portal vein embolization as well as liver venous deprivation to augment the future liver remnant so that you are converting an inoperable patient to an operable patient for a optimal surgical treatment. Ablative techniques also have a role to play, and there's the vast majority of the cases also include supportive interventions, including PTBD. So as I mentioned earlier, interventional oncology now has become an integral component of the overall care. The BCLC guideline, which has been now revised from 2018 to 2022, we know that the loco-regional therapy for HCC is supported by guidelines, and TACE forms evidence level 1A, first line treatment for the intermediate B stage BCLC class. According to the other societies and associations as well, it remains the standard of care. However, in 2025, the NCCN has also included TARE or CERT in the recommendations for a select case of BCLC-C and some cases of BCLC-B. TARE is also recommended in now unresectable the cholangiocarcinomas, intrahepatic cholangiocarcinomas. So the green boxes here highlight the changes that happened from 2018 to 2022. And as you can see that the intra-arterial therapies now can be offered right from stage 0 to convert inoperable tumors to operable tumors. The focus is shifted back to improving the future liver remnant so that the liver resection or hepatectomy is possible, or even to offer transplant to our patients. So to downstage a tumor so that it fits into either Milan criteria or the extended criteria of transplant. So one of the important procedures which improves the future liver remnant volume is the portal vein embolization. So the threshold, as we know, is 25% for a normal liver. And for the hypertrophy response can sometimes even be up to 40 to 50%. The normal liver remnant needs to be much more in case that the patient has received hepatotoxic chemotherapies in the past. The time for increasing volume will also be affected whether the liver is naive of any treatments or whether any chemotherapeutic agents has been used. The background fibrosis and hepatosteatosis will also have an effect when it comes to increase of the level of volume that increases and the time it takes post these procedures. So all this requires a careful consideration. Now this is, sorry for the distorted image, but this is an example of a right lobe portal vein embolization where a glue has been used, the cyanoacrylate glue has been used to completely opacify and block the right lobe portal vein radicals. This is the same case. You can see the baseline PET-CT shows that it has a central mass, which is FDG avid, and you can see the FLR, which has increased from baseline to, which was less than 20%, to after 4 weeks post portal vein embolization, which is 38%. Now, we know that the evidence framework of TACE and CERT also includes that the CERT therapy, or that is TARE therapy, helps in improving the, not just address the primary tumor, but also it helps in improving the future liver remnant, the contralateral lobe hypertrophy. Before deciding these two criteria, these two forms of arterial therapy, we must take into consideration the baseline liver function, and I think the evolving, apart from the Child-Pugh classification, there have been, the ALB score also has been coming in and gaining momentum. So again, coming back, the aim of any intra-arterial therapy can be a palliative care or to successfully downstage a tumor for liver transplant. And when TACE is unfeasible or there's failure, you either combine it with systemic therapy right from the start, or that becomes your next line of treatment. So, it's really exciting the way TARE has been growing and the evidence has been increasing, favoring, the the transarterial chemoembolization to transarterial radioembolization. And if we are able to offer this to our patients right from the start, I think we'll be able to extend the benefits, quite substantially. However, there are several limitations in terms of offering TARE for most of our patients. The radiopharmaceuticals are still imported. These are expensive therapies. And also, sometimes there are anatomical limitations in terms of the altered microvascular anatomy or anomalies, and that's why. But that should not stop us from offering them an intraarterial therapy, and a chemoembolization is still a robust option. As we know, that TACE and TARE have overall overall survival is similar. The time to progression is much better with TARE. However, overall survival remains the same for both. So time to progress, as I said, was mean for TARE is 17.5 months, whereas for TACE is about 10 months. OS overall remains the same. So these are different clinical scenarios that we come across where we have to consider whether it's an unresectable HCC versus inoperable HCC. And although the kind of therapies you offer are similar, the approach that you take and the prognosis of each of these cases is vastly different. Now, this distinction of this intent of treatment cannot be made by single modality, and that's where the role of multidisciplinary team comes in. This is just to highlight one of the TACE cases. You can see the peripherally enhancing lesion. Post-TACE, you can see good amount of necrosis. This is within 6 weeks of the treatment. Subsequently, the patient had significant regression in the volume, was also transplanted. Just to look at what are the alternative therapies, now there is evolving evidence of intraarterial chemo infusion, which is also showing excellent OS, 23 months over 16 months compared to TACE. We also know that different types of TACE, whether it's balloon assisted or DEP TACE, shows improved side effect profile for our patients. Combination of therapies are also important when the tumor size is between 3 to 5 centimeters or over 5 centimeters, and if radiation cannot be used for these patients, a combination of intraarterial therapy and ablative therapy can be used to achieve ablation zones of around 7 centimeters. And when you combine intraarterial therapy with systemic therapy, it also shows much improved survival. So again, now let's visit the 4 different modalities of ablations. Radiofrequency ablation is usually used for tumor sizes which are less than 3 centimeter or up to 3 centimeter in size and less than 3 in number. Overall local control is about 90% at 1 year. Microwave ablation has shown similar efficacy, but it can also give us more larger ablation zones and more volumetric consistency between the sizes of 3 to 5. But both of these are basically thermal ablation techniques. IRE is gaining momentum for areas which are central, which are close to the bile ducts or organs, to reduce the side effect profile. And they've also, even as a palliative therapy, the irreversible electroporation has been used. I would like to also briefly touch upon the role of cryoablation in liver. Apart from the ablative effect, it also confers immunogenic potential and has shown to benefit not just the site where the tumor is treated, but also in the additional sites on the in liver. This is our first case of cryoablation that was done in Apollo Proton Cancer Centre. He's an 80-year-old gentleman with CLD. You can see he's got large surgical herniation of contents, his bowels protruding out. He had several risk factors for anesthesia. He's also had multifocal hepatocellular carcinoma. He was diagnosed in 2022 for the first time. At diagnosis, he was BCLC B category, and he was unresectable at the time. So he's received TACE of segment 1 and 7 lesions. Subsequently, he's had a new lesion in segment 6, which was treated with TACE and microwave ablation. Jan 2024, he had recurrence of segment 1 lesion, which encroached in segment 8, that was treated with proton therapy. And in Jan 2025, while on surveillance, it was also noted that there was a rise in his AFP and PIVKA2 levels, and now the MR showed a new lesion which was barely 1.5 centimeters in size. The patient hesitated to undergo arterial therapies, and this lesion was small. We offered RF ablation as the size criteria fit well into it, explaining to him that he would require conscious sedation to the minimum. However, because of his reluctance to undergo any sort of form of anesthesia, he preferred a modality of treatment which was under local anesthesia, and we could offer him cryoablation. So this is the images that, as you can see, the lesion is well identified on ultrasound, and the ice ball is very discreetly seen while you're ablating, and that makes it very easy for us to assess the margins and whether the entire lesion has been encompassed by the ablation zone or not. You can also appreciate the artificial ascites and the pleural effusion that was created in order to save his diaphragm. So the first one is the pre-cryo images, where you can see arterial enhancing lesion, and the post-cryo images is a beautiful round ablation zone, and this is our whole team, and the patient was awake throughout. So now, in the interest of time, I think moving on, I must mention the collision trial, which is, so far we've been talking about the hepatocellular carcinoma, the primary liver tumor, but in terms of colorectal metastases to liver, the collision trial has also shown that when there are limited numbers of hepatocellular metastases, hepatic metastases, and they are 3 or less than 3 in size, without extrahepatic liver disease, there is no difference in terms of outcome between the surgical resection and thermal ablation. So this collision trial, the key findings demonstrate that it is non-inferiority of thermal ablation for overall survival as well as local control, and hence it is now the clinical relevance of this trial is huge, which basically tells us that we can offer the patients the same outcome with much lesser side effect profile and burden of surgery. And hence both these treatment options are equally good and can be considered for tailoring their treatment. Now there are more work is being done in terms of collision relapse as well as collision XL, which is for lesions more than 3 centimeters, between 3 to 5 centimeters, which also incorporates radiation therapy. This is a unique situation, and I must mention it, where there's a situation of disappearing or vanishing liver metastases of colorectal cancers. You can see a small lesion which is present in the liver, and it has been now marked by a small fiducial or gold fiducial. And you can, I'm not sure whether I have a pointer, but in the second MR image, a black dot which is seen next to the left hepatic artery is the position of the fiducial. Post systemic therapy, neoadjuvant systemic therapy, there is no residual metastases at that site. However, this region still needs to be addressed with local intent, whether either ablation or radiation. And the fiducial helps us to ablate that area, since to start with the lesion was less than 1 centimeter, and hence ablation was given preference. Interventional oncology procedures are not without complications. These are minimally invasive procedures, but we are also equipped to take care of these complications, and I'd like to present a few. I'm sorry, this is just to show the last slide here, that the approach that we use to decide which lesions are likely to disappear, we identify those and mark them before the start of the neoadjuvant therapy. So far, we have not addressed any complications in terms of migration or tumor seeding in our subset. So the complications being, now this is a case of colorectal metastases which has undergone left hepatectomy and has biliary stricture at the anastomotic site. So a metallic stent was placed, which again continues to, with tumor recurrence, continues to have recurrent obstructive jaundice, and he requires biliary interventions. And this is again done very swiftly with interventional oncology. The position of biliary bypass depends on the biliary anatomy and the position of the tumor, and needs to be tailored to each patient. This is another patient. So liver-directed therapy or the complications which involve liver do not arise only from colorectal malignancies or HCCs, but this is other solid tumors can also cause complications which involve the hepatobiliary system and need to be addressed with minimal invasion, most often as they are already undergoing some form of systemic therapy, making them prone for infection. So this is a case of calculus cholecystitis, which had an abscess, liver abscess, also a concealed perf. So we had planned for, she was neutropenic, the patient was neutropenic at the time, and so as an emergency procedure, a percutaneous cholecystostomy was performed. Unfortunately, she did have a complication resulting after this procedure, and there was a large hematoma within the liver. This was identified immediately within 2 hours of the procedure, and she was shifted to cath lab for embolization of hepatic artery and the active extravasation. Now, interventional oncology also plays an important part in pain and palliation. Sometimes when there is a disease along the celiac axis or splanchnic axis plexus, the CT gives us a better guidance in terms of spread of the contrast and the neurolytic agent, and it can be performed, with much better outcome. So, to conclude, the presentation on interventional oncology and also how it functions within the Apollo Cancer Clinic, we have to recognize that there is the multidisciplinary model of care, which incorporates multiple experts, gives us a single point of referral for workflow and a standardized protocol. Imaging, therapy, follow-up, everything happens under one roof. This also, is likely to give very high patient satisfaction, and according to literature, more than 90% of the patients have vouched for that. It also gives us an opportunity to audit our outcomes and also aim for continuous improvement. Road ahead, we are also looking at incorporation of AI algorithms in terms of prediction models, whether a certain therapy, a certain patient would benefit from TACE or not. So the key takeaways, again, I think I would like to highlight our role as part of the multidisciplinary team. So just to highlight that this is a teamwork, and it's great beginning for an issue which is really complex and multidisciplinary. Thank you all.
Thank you, Dr. Mahajan. Next, we invite Dr. Anand Murugeshan to discuss the often unappreciated cornerstone of safe surgery, anesthesia, and pain management in liver cancers. Dr. Anand Murugeshan is Senior Consultant and Lead Department of Anesthesiology and Pain Medicine, APCC.
Good morning, everyone. And thanks for the Apollo leadership. Thanks, Dr. Sujit, for crafting a wonderful, incredible meeting today. And I can see a very good gathering. And the day is so special for me. I have to enlighten here. Like, so happy and privileged to talk in front of Mr. Radhakrishnan, sir. Like, it's my journey with him is like not just as a clinician, like I involved in his treatment care as an anesthetist, as a pain and palliative care specialist. And that has turned out to be a good, family bonding, and it's 2-3 years of good association with him. I'm really so happy to be a treating doctor for him and to talk in front of him. Thank you for coming here, sir. So coming to my topic per se, like as an anesthesiologist, what am I doing here in liver cancer surgery? The role of anesthesiologist in liver cancer is not just about during the surgery. It involves before surgery, like how we plan the patient prepare the patient for the surgery, and of course, like a lot of work involved during the surgery, like This is one particular surgery, like it really gives a nightmare to all the anesthesiologists because of the physiological challenges we face during surgery. And of course, like the meticulous intraoperative anesthesia care we give is prevent them from going into a grave or a serious post-operative complication due to fulminant liver failure. And it's not just stop with only the anesthesia. Like there is one more great role to play for an anesthesiologist, which is an interventional pain management and the pain management as a whole. So the role just not stops with we anesthetize the patient, we shift the patient to the ICU, we continue to follow up the patient, and especially treating their pain. And we all know that the liver surgeries are very major surgeries, and the upper abdominal surgeries pose a great challenge to the anesthesiologist in terms of pain management. This is what I'm talking about, the acute pain management, but there is an entity called chronic pain, especially in terminally in last stages of the liver cancers, like where the visceral pain poses a very severe pain to the patient, like where again the role of anesthesiologist as an interventional pain specialist to come into picture and treat the visceral pain in the advanced stages of the liver. So like if it comes to liver, what immediately strikes for an anesthesiologist like is the liver function is normal. When we are going to give anesthesia to a liver surgery, like what we need to really see when you see the patient first is the liver function, because the liver is the powerhouse of our body, like where a lot of metabolic functions, immune functions are happening. So we need to really look into is the real is already in a normal functioning status or it is deranged. And the vascularity, why it is highly vascular? Because you won't believe the 25% of the cardiac output goes to the liver. So like we have a 6 liters blood in our body, 1500 ml per minute of the blood is pumping into the liver. So which means it's highly vascular structure. It will not give us much time, especially when it start bleeds during the surgery. So as an anesthesiologist, we should be extremely careful to keep the products enough, and also how to manage it's like a sinking ship, like, or it's a turbulence in the air, like as a captain of the ship, what you do in those situations when there is a bleeding happening during the surgery. So there is the significance here, 25% of the cardiac output goes to the liver. And the drug metabolism, whatever medicine you give in the body goes to the liver and gets metabolized by various methods like glucuronidation, conjugation, and by cytochrome P450 metabolism. So any drug you give orally goes to the liver and gets metabolized. And we know in anesthesia, we give a lot of potential drugs that goes to the liver. So when there is a liver function which is altered, or when we are operating on the liver, so these drugs, how are we going to tailor, how are we going to use it in the intraoperative settings really pose a very big challenge to the anesthesiologist. And more importantly, if you manage the intraoperative anesthesia, we are not going to worry about the dreadful postoperative complication, which is called acute fulminant hepatitis in the liver, which has got 100% mortality. So the anatomy, the anesthesiologist should have a very good understanding about the anatomy and physiology. As I mentioned in my previous slide, you know, it has got a dual supply, 80% from the portal vein, 20% from the hepatic artery. So like lot of maneuvers happening during surgery, they do clamp the vessels, and like what happens, like if you cut off the blood supply to the liver transiently, and what all the physiological changes happens during surgery, and how are we going to deal with it? So that we need to understand. And like what are all the important, the hormones or important chemicals which are secreted by the liver, and then if the liver deranged and which is posing a risk during surgery. One is the albumin. Albumin is produced by the liver, and whatever the drugs we give, it's all circulated through albumin. So if there is less albumin, the free drug concentration is more, and we are subjecting the patient to a toxicity of the drug. That is one. And second thing is the metabolic. We know like the liver is mainly responsible for, you know, the glucose metabolization, like gluconeogenesis, then glycogenolysis. So like in a deranged liver, there is a high possibilities their blood sugar drops at any point of time, either before surgery or during or post-op. So having a vigilant look on the patient blood glucose is very important, because like they are the powerhouse that responsible for the gluconeogenesis, and like highly prone for hypoglycemia during any point of their surgery in perioperative period. And their anaerobic metabolism. If the liver fails, then the glucose gets converted to a lactate, and lactose accumulation at the cellular level can shift the patient, tilt the balance to the patient. So these are all the preoperative stratification we do before surgery, like as Dr. Aditya Shah mentioned about the child puke and MEL scoring. That gives us an idea about the severity of the the liver disease, and that makes us to, prepare the patient accordingly. Obviously, for a liver resection, we prefer child puke A, and B and C, we generally don't take it up for a good patient outcome and to reduce the mortality of the patient. And ICG clearance is also something we really consider, like the indocyanine green, to stratify the risk during and after the surgery. Like you give the indocyanine green IV, and then after 15 minutes you check the blood level. If there is no trace, which means the liver function is pretty much good. And if the traces are more, then we classify the liver reserves accordingly. That is going to have a serious impact on the postoperative outcome after a liver resections. And we need to look after the cardiac status of the patient, the lung status of the patient, and the nutritional status of the patient. Of course, the chemotherapy poses a very, very, very serious risk on the patient, the immunology. So like we need to look into the effects of the chemotherapy also when we see the patient in the preoperative period, especially the counts, the bleeding parameters because of the myelosuppression. So these are all the risk stratifications we do when we see a patient in the preoperative period, and according which we take the precautions in the during the surgery. So this is a child puke. Dr. Shah mentioned about it, like we take child puke A between 5 to 7 scoring that has got a very good outcome after a hepatectomy surgery. And this is a mortality rate based on A, B, and C. You see less than 10% mortality even though you take child puke A. You see B and C, like the mortality keep increasing. So that's the significance, like it gives to an anesthesiologist to prepare the patient and to meticulously manage the patient during the hepatectomy surgeries. And the imaging is helping us, as Arunan spoke, like the LI-RADS helps us, like how much of functional liver exists for a patient, like if it is 20% or in a cirrhotic patient maybe 30% or 40%, that again gives us an idea like what is the exact liver status, like because as an anesthesiologist intra we deal with the hemodynamics, like if there is a deranged hemodynamics, we are like depriving the oxygen supply to the patient with already a damaged liver. This is definitely going to risk serious mortality to the patient and briefly about the McCuchie's criteria, which is like more pertaining to the liver surgery as such when compared to child puke. Like where when the bilirubin is more than 2, it's just we suggest to do only a limited resection. But with the normal bilirubin, we do this ICG. ICG of normal after 15 minutes of injection, like where we can do really an extensive liver resection. So like we will allow the surgeon to go for an extensive resection. But if the ICG has got the remnant of 20% or even more than 20% after 15 minutes of administration, we try to limit the resection. We discuss between the surgeons and anesthetists about how limited resection we have to give it to the patient for the better post-operative outcome. So these are all the type of surgeries happens in the liver, and we are prepared to deal with all these type of surgeries as an anesthesiologist. And the most important protocol what we follow is an ERAS protocol, which is an enhanced recovery after surgery. Like this is a custom-made tailored protocol for all the patients. Like we preload the patient with the glucose solution the previous night and 2 hours before. As I mentioned, this is actually applicable for all surgeries, more so over for liver. As I mentioned, they are highly prone for hypoglycemia because of their deranged liver function, and the gluconeogenesis doesn't happen. So the glucose gets converted to lactate. So we need to supplement the patient with glucose 2 hours before we give a good carbohydrate loading to the patient that decreases the catabolic effect of the surgery and also takes care of the intravascular glucose concentration as well. And the standard monitoring, this is one surgery in my experience as an anesthesiologist in 20 years, I would consider as a highly very major surgery, because lot of hemodynamic changes takes place, acid balance imbalance takes place. So we need to monitor the patient intra-op with various invasive lines like arterial line, the central venous line. And in high risk patients, we need to use the transesophageal echo and Swan-Ganz catheters also in selected patients for a meticulous beat to beat monitoring of the hemodynamics, so that it's very important to maintain the perfusion of the liver. So we maintain the CVP of less than 5. To have a good intraoperative conditions for the surgeons to operate. So these are all the monitors we follow, which is, as I mentioned, which is very important. Without an invasive arterial blood pressure monitoring, we cannot proceed with this surgery. Again, we need to have a good quaternary care settings like Apollo, like we have a good infrastructure available to deal with such complex hepatic resections with invasive lines, so that to give the best to the patient. So the arterial BP helps to maintain the pulse pressure variation, which is very important during surgery, that guides us how much fluid to give during the surgery. And the CVP monitoring is also mandatory. We place a central line in the internal jugular vein to monitor the central venous pressure. So this is actually in lot of debates going on, it has got its less significance, but in my experience, this is very mandatory, because we are not going with only an absolute value of CVP. We are going with the trend of the CVP that guides us how much of fluid to give for the patient. And I tend to keep the CVP less than 5 for the good intraoperative hemodynamic, conditions of the surgery happens. So transvasal esophageal echo is an advanced intraoperative monitoring. In selected cases, we use like patients having pulmonary artery hypertension, left heart failure, right heart failure, like where your traditional arterial blood pressure and central venous pressure are just not enough to monitor the patient. So we need to do a transesophageal echo monitoring, where we place the endoscope through the mouth and keep it in the stomach, and then monitor the beats, heartbeats, the chamber details, the right heart, the left heart, the chamber details of the heart. That gives a beat-to-beat information about the cardiac status, the fluid status of the patient, especially in a higher grade of risk patients, like as I mentioned, the heart failure patients. They are very expensive, needs expertise to place, and a lot of training involved, but we have a good transesophageal echo facilities available to deal with high-risk patients who are undergoing hepatic resections. So cardiac output monitoring is actually mandatory, but there is a lot of studies which are coming, which is like outfavoring the use of the Swan-Ganz catheter, because this is highly invasive, because we are placing this catheter in the right heart, in the right ventricle. Sometimes that can, trigger arrhythmias on a patient, especially post-chemotherapy patients. So especially in an oncosurgical liver cancer surgery settings, like this is now going little out of favor. So this is briefly the two phases of surgery. One is the fluid restrictive phase, another one is the resuscitative phase. The fluid restrictive phase is like during the surgery time, like during the surgeons are operating on the liver. They cut the liver till from the beginning of the surgery till the specimen is out is called the fluid restrictive phase, where we try to restrict the fluid to avoid bleeding. Again, as I mentioned, 25% of the cardiac output goes to the liver. So the liver is a very, very big reservoir of the blood. So try to restrict the fluid when the tissue cutting is happening to avoid blood loss and to conserve the blood. And so we have to maintain the blood pressure in those situations with our vasopressors like noradrenaline, dopamine infusion. So the vasopressors takes a predominant role during the fluid restrictive phase, but the fluid, IV fluid, management takes a predominant role after the specimen is out, when there is doing hemostasis. During the hemostasis, you try to bring the blood pressure up with your IV fluids, not with the vasopressor. So these are all the two phases every anesthesiologist should be familiar during the hepatic resection, and each has got its own advantages and measures to take. So what is the ischemic reperfusion? During the hepatic resection, there is a maneuver called Pringle. Like to decrease the blood loss, we have to clamp the portal vein and the hepatic artery. So once you clamp the portal vein and hepatic artery, you are cutting off the blood supply to the liver for the transient period. So once you cut off the blood supply, the liver is going for an ischemic phase. We call it as a warm ischemia. So we should know how long we should administer the warm ischemia, above which the liver can go into irreversible liver damage, or maybe a post-operative hepatic failure. So we allow 15 minutes of warm ischemia clamping and 5 to 10 minutes of declamping, to a maximum of about 60 minutes of warm ischemia time, not more than that, or else like we are pushing the patient to a fulminant hepatic failure in the post-operative period. So this is a very, very important step in the liver anesthesia in liver surgery, where we need to be extremely cautious enough to monitor the warm ischemia time. So post-operative care involve a meticulous ICU monitoring, especially the bilirubin, especially for monitoring the post-operative hepatic failure. So the bilirubin monitoring is more important, the INR monitoring is very important, and the encephalopathy monitoring is very important. This will tell us if the patient is going for the fulminant hepatic failure after the hepatic resection. Of course, glucose monitoring, as I mentioned, very important hour to hour, and to correct the blood sugar, then and there is very important to prevent hypoglycemia-induced injury. So next we move on briefly about how are we going to manage the post-operative pain. That's very important, because if it is done by a minimal access surgery like robotic and laparoscopy, the pain is less. But we will not be in the situation all the time with only minimal access surgery. Sometimes we may have to convert it to open surgery for whatever good reason, and it is going to be a Mercedes-Benz incision, which is going to be a highly painful incision for the patient. So the post-operative pain management is again a very, very important challenge for the anesthesiologist, where we do a opioid sparing technique. Why specifically I am mentioning opioid sparing means opioids are the very strong painkillers, again gets metabolized in the liver. With the deranged liver settings, the accumulation of the active metabolites of the opioids can cause serious side effects to the patient. So we administer thoracic epidural. We call it as a congruent analgesia technique, like higher epidural again needs an expertise. We place it at T5, T6 or sometimes T6, T7 level to give only the segmental analgesia to the place where the incision is given. So thereby the patient gets a very good post-operative pain relief. He cooperates for good physio. He do a very good chest spirometry, and thereby his surgical outcome will improve, and his stay in the ICU also is minimized. So there are a lot of papers available, like why the opioid sparing techniques in post-operative pain management is so pivotal in upper abdominal surgeries like hepatectomies. So this is our operation theater suite, like how the patient is placed in the table with a nice head-up position, and with all the monitors what I have mentioned so far has been in place during the surgery. So little bit I would like to touch upon the chronic pain. So now if the patient falls under an unfortunate category of inoperability, like we are not going to give surgical clearance to the patient, and patient came with the higher stages of surgery, and we have to head towards a palliative care, which is again a very, 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 very important domain in liver cancer care. Believe me, significant portion of the patient will come in this particular category, where we need to have a proper protocol. How are we going to deal with it? Because why these are all very important? Because visceral pain is not so as easy where we think. It is like considered more severe than your somatic pain, like or the post-operative pain, or a fracture pain, or even the labor pain. It is even more worse than all these type of pain, because the anatomy is so complex. You can see here, it passes through the visceral fibers, the general visceral afferent fibers passes through ganglions. One is the peripheral and the central dorsal root ganglion, with a lot of representations of the nerve fibers, sympathetic fibers comes from the liver. So that poses a very, very severe pain if the liver capsule gets stretched because of either metastatic liver disease or from the primary hepatocellular carcinoma. So we need to have a proper plan. How are we going to treat this patient's pain if they come with the highest grades, or with the pain comes from the viscera, liver viscera? So the quality of life is very important. What is the point in living with pain? So like from patient's perspective, we have to think from we should not think only about from the doctor's perspective. You can give chemo, you can give radio, you can give surgery, but like what the patient needs is a good quality of life. They have to eat, they have to sleep, they have to walk. The mobility is very important. So like we should always think from patient's perspective also what we are going to offer them in the process of the whole treatment. That's a good quality of care, which is very, very important, because the psychological and the emotional component in chronic pain are very, very important for the patient, should be included, should be thought when we are treating the patient at any point of time. Patient assessment is, pain assessment is very important. Are we dealing with the right pain? Sometimes the pain may come from some other place, so your assessment is very, very important. So what are all the two different types of chronic pain managements are available for the higher stages visceral pain of the liver? One the pharmacological, another one is non-pharmacological. So we are moving away from the pharmacological methods because of the obvious disadvantage of the opioid therapy we administer to the patient. As I said, like these are all the problems with opioid we generally give for pain relief. Traditionally, we all know pain means morphine, pain means tramadol, but we have a problem with all these drugs when we give in advanced stage, especially in the liver cancers with the deranged liver. Tramadol is not very effective because of the reduced bioavailability. Pethidine is contraindicated because of increased bioavailability. And you take morphine, it has to be administered with extreme caution. This is very important. Like I would like to make an emphasis in my talk. If one point I would like to emphasize here is about morphine. Anybody comes with abdominal pain due to liver cancer, we think immediately of giving morphine. See, morphine has got an active metabolite. It undergoes glucuronidation in the liver, and the morphine 6 glucuronide is a highly potent than the parent compound itself. So with this active component, we try to give more morphine, like we are pushing the patient to the side effects of the morphine, which we all know, which is very dreadful. They can stop breathing, they will have ileus, they'll throw up, they have severe vomiting, and their quality of life is thoroughly screwed up. So like we are moving away from opiates because of all these reasons. So then what is left? We are not giving morphine, we are not giving opiates, so how are we going to manage? There comes the role of interventional pain management, which is like extremely targeted. We know in my previous slide I mentioned about the fluxus, like we have a celiac fluxus which supplies the upper abdominal structures more so over the liver. So there are ways, fluoroscopic ways, ultrasonic ways, you can reach those fluxes and you can ablate those nerves, which is extremely targeted and has got a superior role of analgesia when compared to the pharmacological method of managing this liver pain, the liver visceral pain. It can be done either by a fluoroscopy or ultrasound, and of course by CT guided also. So I'm collaborating with Dr. Mukta, like to do it with the CT guided for a better precision and for the better safety of the patient. So there are various approaches are available in celiac plexus. What the approach I use is your anticrural transaortic, which is slightly risky to the patient but more effective. With our thanks to the Apollo, with 15 years of the experience, the journey undergone in the pain in palliative care, I will be able to do this transaortic approach effectively on those patients with the visceral pain, and they are able to get a very good relief. And this is your conventional technique where 2 needles are placed and then we ablate the celiac plexus, now which is going out of favor because of lot of paraplegias are reported because of the neurolytic agents seeping backwards and then causing the paraplegia to the patient. So the transcrural is one I prefer in moribund patients. What if you can, this particular procedure should be done in the operation theatre in prone position. What like if patient is moribund, he is going to live for a week or maybe a month and he is on inotropic support. You can't move the patient from the ICU. Still you can offer them a good pain relief by choosing an anterocrural approach with using an ultrasound, like where the needle is placed at the bifurcation of the celiac trunk between the hepatic artery and the splenic artery juncture. And then you can inject the neurolytic agent to give a better pain relief. This is the advantage where you can do it at the bedside. So lastly, the splanchnic nerve, which gives equal result like a celiac plexus ablation, like this is given before the diaphragm, celiac plexus is given after the diaphragm. That's the difference, but it gives good results. It is done at the level of T11, T12 vertebral level, where the greater, lesser and the least splanchnic nerves converge, pierce the diaphragm and enters intra-abdominally. You can reach the T11 vertebrae and then do the ablation, and then that takes effectively for the liver visceral pain. Lot of literatures are supporting the interventional pain management, especially the celiac, the splanchnic for the liver visceral pain. So the neuroaxial blocks and neuromodulations are the recent advances. Even if these measures interventions fail, we can still place a catheter in the intrathecal space, and then that is connected to a pump, and the pump is filled with analgesics like morphine, and we can give. You will be wondering, like what doctor said, like he has spoken about lot of adverse effects of morphine, but he is telling morphine should be given intrathecal. Yeah, there is an answer here, because the morphine what we give in intrathecal is 1/300th of oral morphine what we give. 1/300th of morphine what we give in intrathecal, so it takes care of an analgesic effect without having any side effects of the opioids. So we have a good literature supporting the neuromodulation effect of intrathecal pump in liver cancer surgery. So have a thorough good clinical assessment, and the pain generator is something which we need to identify, which is very pivotal, and early intervention is important, and neuromodulation is the future. Thanks for the patient listening.
Thank you, Dr. Anand, for that insightful talk. This brings us to a well-deserved tea break. So kindly join us, have a break, and kindly join us back for the inaugural ceremony.
I request everyone to be please seated. We'll shortly start the inaugural ceremony. I request our chief guest, Mr. Radhakrishna Tyagarajan, IPS, retired ADGP, to kindly grace the dais. We shall now proceed with the lighting of the lamp ceremony. I request Mr. Karan, CEO, APCC and ACC, to join us. Dr. Ilan Kumaran, Dr. Mukta Mahajan, Dr. Arunan, Dr. Jaykant, Dr. Sujit Kumar Mupalli, Dr. Ashu Abhishek, Dr. Alec Korea, Dr. Anand Murugesan, Thank you, dignitaries. Now I would request Dr. Sujit Kumar for the welcome address.
A warm welcome to all of you to the launch of Advanced Liver Cancers Clinic. We call it as ALCC at APCC. It's an honor and a privilege to be in front of Mr. Tyagarajan Radhakrishnan IPS. I have the honor to be with him in his journey for last 3 years. Actually, sir walks every day for around 3 to 4 kilometers. Recently he had a fall, after which he has been advised not to strain too much. Otherwise, he's much more fit than many of us here. And I remember 3 years back when he came to the room, as usual, I was not knowing who is the patient, and I asked, I was seeing the report, he said, Dr. Sujit, this is my report, tell me what should I do? The same that you can feel the sense of a policeman when you hear his voice. And and that is the spirit, and that was so much inspiring for us. You see, that attitude is what most important, I would say, for us to start the journey. So why we decided to have ALCC or Advanced Liver Cancer Clinic is because liver cancers are rising in Tamil Nadu and in India. There has been around 66% increase in the incidence as per the ICMR data. And it's very important to have a team behind the treatment because we have a multidisciplinary approach here. We have the hepatologists, the radiologists, interventional radiologists, nuclear medicine, radiation oncologists, surgical gastroenterologists, surgical oncologists, medical oncologists. So there's a big team behind the treatment, and if we are able to sit together in a tumor board and discuss the plan for the treatment, it always is the best and optimum treatment plan. Without much words, I request Mr. Karan to come on dais, and we will have the launch of a book which has been written by Mr. Tyagarajan Radhakrishnan IPS about his journey, and I wish everyone in the audience to give him a great claps. I request few words from our chief guest and our privileged honor guest here. Radhakrishnan sir, can you speak few words for us?
Yeah. Dear doctors and sisters, my dear family from USA, from Singapore, from Bangalore, everybody. Dr. Sujit, Dr. Anand, Dr. Alak, Dr. Asabhishek, Dr. Sujit, I am alive today because of them. I was diagnosed with the 4th stage cancer in 2022.
Don't be emotional, sir.
I'm very happy. I'm very happy to inaugurate the Center for Liver, Advanced Center for Liver Clinic. I'm very happy. But for Apollo, I will not be alive today. But for Dr. Sujit, Dr. Alak, Dr. Asu, Dr. Anand Mriyasan, Dr. Kadar, Dr. Sudipta, he has not come.
He's coming.
Dr. Sudipta, Dr. Kadar, he has not come. Dr. Alak, Dr. Anand Mriyasan, Dr. Anand Mriyasan was Dr. Indumadi. Indumadi has not come.
He's in a surgery.
Oh. I had been, Dr. Sudipta has come here. Come, Doctor. Dr. Sudipta. He was the surgeon who operated on me. And I have written very, very brief booklet about my journey. Very brief. They have become our family members. They treat me like their own father. They treat me like their own father. The first day I met Dr. Sujit Kumar, he never thought that I was a patient. Patient was somebody else. I told him I am so-and-so. I am the patient. And he took 1 hour. I told him, you must take 1 hour. Dr. Arunan, Dr. Prasant, where are you? You have not come. Dr. Arunan, Dr. Prasant, they have not come. Convey my best wishes to them. Sujit Kumar took 1 hour to brief me about the disease. He told me, you must have positive attitude, strong mind. Number 2, finance. Number 3, family support. Number 4, God's grace. I have got all the 4. That's why I am alive today. See, my family has come from USA, from Singapore, from all over the world. They come. Every operation I have survived 18 chemos. 18 chemos, 28 days of radiotherapy. Dr. APCC knows.
You see, so what he had at 2022 July, he was diagnosed with CA pancreas with liver mets. So it's not very common to treat oligometastatic pancreatic cancer with a curative intent, because as I said, he was 69, but he looked much stronger and fit. We decided we'll go with FOLFIRINOX protocol and then go for liver surgery. And he underwent a metastectomy. Dr. Sudipta did the metastectomy, and it was a CR. And till now, for the last 3 years, the liver has not had any single metastasis. Although he had progression in the abdomen, there was a nodule later on in the pleura, but liver is still free. So that is what we wanted to highlight in a liver cancer clinic, that it is still possible to have a curative intent treatment. Now, why is sir so emotional is because 2-3 months back, he had a very severe cardiac arrest, and he had a triple vessel disease. And it was a very difficult time for him in the ICU. For many days, he was in the cardiac ICU in Apollo, and I think it's very natural for him to feel emotional in front of his family. This book he has written after he completed his journey in 2022, and we are privileged to have the inauguration with the launch of his book, because ultimately, as you all know, the clinicians here know, the patients and the families are the people who motivate us to do better. It's not about APCC or anything. As a doctor, as an oncologist, that is what drives us. That is what drives us to do better for all of us. And it's a great privilege to have Radhakrishnan IPS sir and the family here. Thank you so much for coming here. And it is memorable because your presence is here. Thank you so much. I'll request Dr. Sudipta to say a few words, and then we'll go on to the academic session.
Radhakrishnan sir is a fighter. That is along with what we have done. So he is a fighter, and he was always positive, and he never had a single doubt on the management plan. And whenever our face will have some anxiety, but I have never seen anxiety on his face. So that is the great thing about him, and the family is so supportive, and they are so so much supported him. And even if he comes to clinic in a wheelchair also, you won't see any anxiety or any depression on his face. So that is one point, and the positive thinking helps us to go through the difficulties. Of course, we have an expert group of people starting from the medical oncology, radiation oncology to the surgeons, but we need the cooperation and positive thought process from the patient and the patient family, which helps us and encourages us to fight and do the best for the patient. Thank you.
We have a small gift. I request Mr. Karan Puri, CEO, APCC and ACC, to hand over a gift to the family of Mr. Tyagarajan Radhakrishnan for making their presence here. Thank you so much. Yes. This is, Madam is Mrs. Tyagarajan Radhakrishnan IPS. I hand over the mic to Dr. Anupama to continue the academic sessions.
Let us resume our academic journey. With a strong clinical foundation laid, we transition now to surgical tract, exploring transformative approaches in liver cancer surgery. I welcome Dr. Ilan Kumaran, Senior Consultant, Liver Transplant and Pancreaticobiliary Surgery, Apollo Hospitals. With over 17 years of experience, over 5,000 surgeries and over 1,500 transplant surgeries. He has many awards and records to his credit, and also complex multi-organ transplants.
Display, want to check the display, yeah. Second slot, yeah. You are connected. It's not disconnected, it is connected. Hearing a screen mirroring la polama. No HDMI. Built-in display, no HDMI, then I want to. அதில் அது சார்ஜிங் போட்டான் அப்படியா சரி ஓகே ஃபைன் சரி இப்போ இந்த மாதிரி ஆயிடுச்சுன்னா கனெக்ட் ஆகிடுச்சுன்னு அர்த்தம் A very good morning and warm welcome to all the delegates, distinguished professors and friends. I really feel it is a big privilege for me to be here. Like how Dr. Sujit was mentioning it, it has been a dream come true for us to start this advanced liver cancer clinic, because I think this is a very unique clinic in the sense that no other facility in the country or probably in the entire region, Southeast Asia, has this ability to provide everything under the same roof, the highest of radiation interventions, the highest of the best chemo and immuno advice, transplant, surgical, and so everything is at zenith in Apollo Proton, and I feel very proud to be associated with the Advanced Liver Cancer Clinic. And I would like to start by thanking our beloved chairman and our leadership at Apollo, who have given us this ability to dream of working in a world-class facility here and do the best for our patients. And as we are all aware, liver cancer definitely is increasing because of a lot of reasons. It used to be hepatitis and alcohol-related cirrhosis, but now even the rising epidemic of fatty liver has been a big threat for developing liver cancer, and I'm sure we are going to see many more patients with liver cancer in the future. And oftentimes somebody having liver cancer, this is how they are looking at a dark tunnel, and suddenly there appears the intervention of the radiation oncologist with a lot of promise. And also there is sometimes very enticing interventional specialists who come with their own aspects of treating liver cancer, and with a very strong chemo and immuno options are also available. And finally, patients comes with his own Google therapy, but then the only superstar is always surgery. And with surgery in hand, you can always think of liver cancer as the cancer is gone and liver 2.0. Transplant has that ability to replace the liver with a new and functional and going to support him for the rest of the life. And there comes the birth of a new specialty called transplant oncology. It has always been the dream of mankind to replace like with like, kind with kind. And if you can do it for cancer, there is nothing better treatment. And so this specialty of transplant oncology. It all started with the father of transplantation himself, Professor Thomas Tarzell, who did the first successful liver transplant in 1963. He did a series of almost 7 patients with liver cancers transplant. He found them very much more easier because, as you are aware, cirrhotic patients have a lot of portal hypertension, they have a lot of systemic complications, whereas patients with tumor do not have all this. And hence, the transplant outcomes were much better, the perioperative outcomes. But then, as the follow-up happened, they all found out that they were not suitable because even the first child sitting on the lap of the Dr. Carl Groth, he was a Swedish surgeon working with Professor Tom Starzl. The child died in 1 year with recurrence, and subsequently for almost 3 decades, liver transplantation for tumors were scoffed at. People were scared of doing transplantation for tumors, and it is only after 3 decades in 1990s, in the 96 exactly, when Professor Vincenzo Mazzaferro and of the Milan group came up with their publication of selected patients with HCC having a very good outcome with liver transplantation. It became a reality. And factors which actually fuel the renewed interest in the field of transplant oncology is how it has evolved with newer systemic treatments and direct acting antiviral therapy. Even our knowledge of the transplant and tumor immunology has improved and helped us to select the patients better. And finally, definitely technical innovations in transplant has made it a very safe operation in all the experience centers. So the conceptual frame of transplant oncology happens to be with its benefit. The survival after liver transplant has the best alternative treatment, and the 5-year survival of over 60% initially was accepted as a very sensible outcome, and because the selection was always done with more than just morphology criteria, they have been started to select with dynamic biology-driven criteria. And the pillars of transplant oncology with evolution of multidisciplinary care, exploration of the disease mechanisms, elucidation of the transplant and tumor immunology, and finally the extents of transplant and hepatobiliary surgery for liver cancer has extremely widened. Coming to the most accepted indication, the hepatocellular carcinoma, you see this pale looking large tumor in the liver. Hardly these kind of tumors can be resected, giving a functional remnant, and aiming for cure looks like a distant possibility. But then it continues to be the broadly accepted cancer indication for liver transplantation, and accounts for almost 40% of the waiting list in Europe and about 25% in the US. And we all know that every cirrhotic patient almost has a risk of 1 to 5% of developing hepatocellular carcinoma every year of survival. And 90% of HCCs actually occur in a background of a cirrhotic liver or a diseased liver, sometimes with viral hepatitis, and now, like I said, recently the scare of fatty liver induced chronic disease. And the tumor microenvironment in the liver has a potential to produce multicentric tumors, of which at least 30% are unrecognized before the pre-transplant imaging. And like I said, these were the initial attempts before transplant when we tried to resect very complex tumors like this one, which is located in the anterior to the cava behind the liver. These are practically needs completely what we call the ex vivo liver resection. You take the liver out, resect the tumor, and you can auto-transplant the same liver. So with all this experience, certainly we have had the confidence to go ahead with liver transplantation for cancers. And the most popular, widely accepted Barcelona Clinic liver cancer update in 2022 still recommends transplant as a safe indication for patients in the intermediate stage. Because for the very early stage, we still have very effective radiological options, and even the recent advent of SBRT and now the Proton, I think they will all be very effective treatments for these patients. And advanced, definitely transplant is going to be out of the purview, and immunotherapy is come up in a big way. But then the intermediate stage still continues to be a heterogeneous cohort, and the introduction of the option of liver transplant has given a completely new option for these patients. And portal vein tumor thrombus used to be an absolute contraindication, but then the experience in the eastern part of the world has given us a new indication, whereas segmental portal vein, the right, second and third order portal veins need not be considered as a contraindication for transplant if, along with the considering the biology of the tumor, if they have a low levels of AFP and low FDG avidity on the PET scan, and the tumor sizes are also not very big. But then hepatic venous tumor thrombus considered to be a systemic disease. So several expanded criteria have come, like I said, from the eastern part of the world, starting from the Koreans actually, and then finally, so this is the Tokyo criteria, Kyoto criteria, ASEAN criteria, and our own the Delhi experience from Medanta Hospital has shown that patients with no extrahepatic invasion or no major vascular invasion, irrespective of the tumor size or number, can be suitable candidates for liver transplantation, with almost reported of 64% overall survival and 70% recurrent-free survival at 5 years, which is cannot even be imagined without transplant in these patients. And definitely the advent of downstaging has brought up a big avenue for in preparing these patients for transplant. And like I said, they are also observed for a minimum period of 3 months between completion of downstaging, and only then they can be considered suitable for listing. And the retreat score, which actually looks at the survival, recurrence risk based on the AFP level, microvascular invasion, and the largest tumor diameter. These are all very important parameters to look at how these patients can be followed up after transplant or a resection. And the next common indication for transplant can be colorectal liver metastasis. We all know that 50% of patients with colorectal cancer develop liver mets, and liver is the most often involved metastatic site, with almost 30% of tumor metastasis in the liver, and 17% occur as synchronous disease and 10% as metachronous disease. And surgical resection offers the only chance of cure for long-term survival. The 5-year overall survival is almost 60% compared to less than 5% for palliative care, and there goes the justification for transplant or surgical resection in these patients. And the principle still is that if you can maintain an adequate future liver remnant, resection is enough, and if you do not have an adequate future liver remnant, transplant can be a suitable option. And CRLM is the only transplant oncology indication that is supported by level 1 evidence, because there are randomized controlled trials that have come from Norway, which have given us the proof. And before transplant, they were to augment the liver remnant, we were using several techniques like the parenchyma sparing surgery, or portal vein embolization, or the ALCC surgery, which means a two-staged surgery where the first stage involved transection with portal vein ligation, which actually mimics like liver has been removed, and the hypertrophy starts getting very in a rapid rate. And normally the embolization, if it takes 1 month for the remnant to hypertrophy, by ALCC technique within 2 weeks the hypertrophy can happen, and then you can safely go ahead and resect these tumors. So still I would say transplant for CRLM continues to be in a very select group of patients with more than thousands of patients for surgery and 10,000s in palliative care, only selected patients for liver transplantation. And when you compare the groups that were studied in the first randomized control trial, the SICA-1 trial from Norway, you can see that the overall survival was almost 54% versus 11%, and the disease-free survival was 34.5% versus 0% with non-transplant options. And the SICA-2, it selected the cohort based on SICA-1, but then as you can see, it proved even better, where the overall survival on an intention to treat basis was almost 83% and disease-free survival was 35%. The TransMed trial came later, has compared liver transplantation with chemotherapy to chemotherapy alone in patients with unresectable colorectal liver mets. And like I said, the 5-year survival on an intention to treat was 56, whereas patients who were able to complete the protocol, per protocol basis, it almost increased up to 75%. So this was a new technical innovation that came from Paul Dagline, the Swedish surgeon, who showed that transplant can be done safely by a technique called a rapid procedure, where in patients with the unresectable bilobar liver metastasis, the first stage involves just doing a left hepatectomy and putting in a left lateral small segment graft. So you are not risking a living donor if they are donating a left lateral donor, or if it is a cadaver donor, you can split, and the allocation becomes ethical, that you're not wasting for a cancer or a wasteful indication. And also ligate the portal vein on the right lobe, the remnant right lobe. By this technique, like the ALCC surgery, the left lateral segment actually augments to support the patient in less than a month's time, and after that you go ahead and remove the right hepatectomy. So in this way, you are able to completely remove the bilobar mets with a very small graft that can be taken either from a living donor or a cadaveric split liver transplantation. It was introduced in 2015. This technique still continues to be in evolution. It can be done with, like I said, both the deceased donor and the living donor, and only 23 cases till now have been documented. So this is another schematic diagram. You see metastasis all over the liver. The first step is to remove the left part of the liver, left lobe of the liver, and then implant a healthy left lateral graft. And once the left lateral graft is hypertrophied, you go ahead and remove the right lobe. This rapid procedure can definitely serve as a useful alternative for a lot of patients. This is one of the surgical pictures showed in one of these studies. And the next procedure came up. The other innovation was to do a heterotopic transplantation, where the splenectomy was done and the left lateral lobe was actually placed in the splenic fossa, with the splenic artery and vein helping for the inflow and outflow. And after the graft has hypertrophied, you can actually go ahead and do a complete total hepatectomy. This Rava's procedure has the advantage that you do not meddle with the portal structures, and hence the surgery becomes much simpler in both the first and second stage. So there are very strict guidelines in which patients you can offer transplant based on the primary tumor, the criteria of the metastasis, the testing of the biology of the tumor, and finally also looking at the molecular criteria. I will leave it to you for further reading for short of time. So then other commonly studied disease for transplant is hilar cholangiocarcinoma. It was first attempted by the same man, Thomas Starzl, in 1963, and early results were very poor due to poor selection, and there were no standardized protocols at that time. The Mayo Clinic developed a very rigorous protocol in 2000 and actually revolutionized the outcomes. It was the preoperative protocol involved giving chemotherapy, radiation, staging laparoscopy, and then complete the neoadjuvant protocol, and finally give a cooling off period. And if they are able to maintain a disease-free period or not a growth, with no further spread, they were offered transplant. And the updated results of transplant in these patients who completed protocol showed a 82% 5-year survival and 14% recurrence, which was definitely cannot be achieved without transplantation. So it went on to a point where even the UNOS, the United States Organ Distribution Network, accepted hilar cholangiocarcinoma as a indication for listing in the cadaveric waiting list. And like I said, there are several inclusion-exclusion criteria. Still the accepted protocol continues to be the Mayo protocol, the original and the subsequent ones. And the surgical protocol also, as I said, follows later. And even intrahepatic cholangiocarcinomas, we all know that there are several variants, the mass-forming variant, periductal variant, the mixed and the intraductal growing variant. You can have a very selected group of patients and who can actually benefit from transplantation. Typically, the mass-forming lesions are suitable for transplant, and there have been a meta-analysis in 2020 which showed a pooled 5-year overall survival of almost 42%, which again is a significant improvement over non-transplant indications. And there are several protocols. The other major accepted indication is the neuroendocrine liver metastasis. We know the famous patient Steve Jobs had a liver transplant for neuroendocrine liver mets, but then he was at a very late stage and did not have the expected benefit. But then these continue to be very successful indications, and when there are bilobar mets and having functional disease, definitely more than debulking or resection, transplant has a better tumor-free or overall survival. And Milan group has come up with a separate criteria for selecting neuroendocrine tumor liver metastasis for transplantation, and the comparative outcomes for resection and transplantation show that transplantation continues to be a much better choice. And in children, hepatoblastoma is one of the primary indications for a primary liver transplant, and basically they are done in children with tumors showing poor response to neoadjuvant chemotherapy. A lot of children have a very good response to the extent that even bilobar hepatoblastoma tumors show a response to, and then you go ahead and do only a liver resection. But then if they're not very responsive, then definitely maybe an indication for salvage liver transplantation. And the 5-year survival in these children continues to be very good, more than 90%, and even children having a resectable lung metastasis continue to be good indications for liver transplantation after the lung metastasis has been treated. And even rare tumors like hepatic epithelioid hemangioendothelioma, they are a very potentially malignant tumor, but then cannot be resected in most patients because they continue to be bilobar and large tumors, and so resection cannot be offered to them, and transplant continues to be a cure for several of these patients. I'd like to end by showing some of our successful patients who underwent transplant for cancer. This patient was diagnosed with cirrhosis and liver failure, had recurrent hospital admission for decompensation. He was stabilized with medical management and evaluated for liver transplant, and there were a lot of incidental tumors that were detected on evaluation, which continues to be very common in a lot of these patients. He was waitlisted for a deceased donor liver transplant. He underwent a successful transplant, and there he is exactly 2 weeks after transplant. And oftentimes the success of transplant is for the entire family. And this child, 2-year-old, was evaluated for an abdominal mass, had raised AFP, received chemo almost 4 to 5 cycles, was unresectable at the end of 4 cycles, and finally underwent a successful living donor liver transplant. And the child was discharged as early as 8th day after surgery. And as you can see, the picture above is a pre-operative and the picture below is the post-operative picture. There's no difference. The child is actually doing what he's supposed to be, playing with the toys rather than fighting for his life in the hospital bed. And this young lady, 25-year-old, came to us with evaluation for pain and weight loss. She was diagnosed with the rare tumor, the hepatic epithelioid hemangioendothelioma. We counseled the family for transplantation. The uncle was fit for liver donation. She underwent an anemonical surgery, recovered well, and as you can see now has a kid after transplant, and that goes on to prove the success and normal life after transplantation. A few slides about the recent advances in transplantation. Definitely I have to mention about the role of minimally invasive surgery, robotic surgery. And as you can see, this 73-year-old man was referred to us actually from Apollo Proton, and after a successful robotic left hepatectomy, on day 1 he was able to mobilize. A 73-year-old man walking 1 day after surgery cannot be achieved with an open surgery, and he was discharged on day 3 actually. So this was the CT scan, and this was the resected tumor that was taken by robotic surgery. I am sure Dr. Bala will mention more of these cases. And robotic surgery, the advantage is not just with these cosmetic scar, but then I would say the typical incision that we use for robotic surgery, open surgery, is a upper abdominal reverse L scar, which interferes with the breathing in the postoperative period. It's an upper abdominal incision, muscle cutting incision, so respiratory complications are a little higher than normal, whereas in the robotic surgery the ports are placed at the level of the umbilicus, and there is a phalansteal incision. It is a muscle splitting incision, and so the respiratory recovery is faster. The chances of incisional hernia, adhesive obstruction, all these are much less with minimally invasive surgery. And we have started using the robotic surgery for donors. This is not a child with tumor, but then the child with biliary atresia, the father was supposed to be the donor, and this is typically the position of the ports at the level of the umbilicus. And as you can see, at the time of discharge, the donor has recovered so well that he can actually take care of the kid himself. And like the Terminator would say, the machines will rise. They have risen in transplant also. There are newer machines in transplant which can actually increase the preservation time and also improve the quality of the graft. You put in a fatty graft, it can give you a normal graft. And there are now research showing that you can put in a B group graft, perfused with specialized pollutions in these machines, and take out an O group graft which can be transplanted to any patient. And this is a normothermic machine. There are two technologies in perfusion, normothermic and hypothermic. Normothermic is, we have used a few times in India, and the machine is not anymore available here. This is the normothermic machine, where the machine is placed in this box. The situation is like the normal human body. The blood is passed in the hepatic artery and portal vein, and the effluent blood can actually be checked with biochemical parameters like lactate, bilirubin, enzymes, and you can proceed with the recipient surgery only when you are convinced with the functioning of the graft. And this hypothermic technology is available now. It is much less cheaper. We've been using routinely. We used more than 16 of our patients and has been very successful in all these patients. So our liver transplant success rates are increasing. The last 3 years, first year we did 64 with almost 90.6%. We had 4 mortality out of 64. And in this next year, we have done almost 80 transplants and had a mortality of 6 patients with 92.5%. And this year we've done 42 more now, and we lost just 1 patient with a success rate of almost more than 97%, which is, it just goes on to show that transplant is not anymore an operation to be dreaded. It is a very safe operation. And to me, as a transplant professional, it definitely cannot be called as magic, but it's medicine. But then definitely it is a miraculous treatment, and it can be successful only if there is an early referral and there is a good optimization, and definitely we need the best multidisciplinary care. Once again, I thank our Apollo management and our team here at Apollo Proton for giving me this opportunity. Thank you so much. Sorry if I have taken more time.
Thank you, Dr. Ilan Kumaran, for walking us through the liver transplant in cancer care. Continuing with surgical complexities, we now welcome Professor Dr. Sudipta Kumar Swain. With over more than 21 years of experience, he is the leader in robotic and laparoscopic hepatobiliary and liver surgeries. He specializes in minimally invasive management of liver tumors, gallbladder cancers, and complex HPV cases. He is a passionate educator, mentor, and researcher with more than 30 publications in GI and liver surgery. Over to you, Dr. Sudipta.
Good afternoon. That was a nice presentation by Dr. Ellen. And this is an interesting topic which I wanted to discuss. And when Dr. Sujit asked which topic, I choose this. The dilemma of disappearing liver metastasis. If a common man, if you ask, they will be thinking that liver mets are disappeared. Then what to do? Should we operate? Should we treat that? Should we follow? Or just forget it? But actually it is not like that. So let us start. What is this disappearing liver metastasis? The liver metastasis which on follow-up, whenever you have a liver metastasis, we are particularly discussing the colorectal. There can be metastasis from other regions, but the disappearing liver metastasis is mostly discussed for colorectal cancer and the metastasis to liver. So because in colorectal cancer, if the liver metastasis is there, this is not end of the road. Still it can be treated, still it can be resected, it can be re-resected. That is why we are discussing about the metastasis, and whenever we have a metastasis, most of the patient, they get a systemic therapy first. Systemic therapy means chemotherapy and immunotherapy to control the systemic disease. So in that, when we start chemotherapy, after some time when you follow up, you see the liver metastasis is gone. It is not visible in the standard imaging studies. So that is disappearing liver metastasis. So what is the background when if you see the colorectal cancer, because there we do most of the liver resection for metastasis. 50% of colorectal cancer will develop metastasis at some point of their disease. 10 to 20% of patient are for curative surgical resections, and this newer systemic treatment modalities like chemotherapy with immunotherapy has increased the survival. Even with liver metastasis, we have a survival rate of more than 75% at 3 years. So what happens when you give systemic therapy? 50% which were on not resectable at the initial stage, they become convertible to resectable, and 20% get curative resection, and complete radiological disappearance means you are no more able to find it. It happens in up to 37% of patient with the present mode of therapy. So what happens? Has it disappeared completely? Is it going to come back? Are we going to treat it? 11 to 65% in different studies have seen this localized residual disease at the site where we thought it has disappeared, but it is still there. And whenever we resected that without seeing or finding it on image, we have seen 80% of the specimens will have residual microscopic disease in that area. So suppose some patient opts for no, or he loses follow-up thinking that he got cured. 74% of them come back with recurrence at the site where there was a disease. So occurrence, you saw the metastasis there, then you saw it has disappeared with the systemic therapy, then you saw it has come back. So this is how it is. So when to treat, which one to treat, how to treat, that is important. So we understood the phenomenon of this disappearing liver metastasis is a radiological finding rather than actual biological occurrence. That is what we have understood with the present evidence, which may change. So how to treat that? A high quality imaging. Which imaging? We have to look for it. Proper assessment and planning with a multidisciplinary team. Then aggressive surgical approach. So radiological imaging, we have so many gadgets, so many options, like you go, somebody says do a CT scan, somebody says do a PET CT, somebody MRI. So which one to treat, which one to choose? So if you see this PET CT and MRI CT, most sensitive method of detecting is the MRI, which detects even the smaller lesions, both pre-treatment and post-treatment with systemic therapy. Of course, with MRI, if it is diffusion weighted, if you have given a contrast like gadoxetic acid or gadobutyral, so you will have more sensitive or more easily found lesions than without this. My radiological colleagues are there, they may add on to this. If you see the initial picture, that's a CT picture, and you see the MRI picture of the same patient at the same time. There is a difference. The tumor is more evident on the MRI than what we get in the CT scan, even if with the best 320, 640 slice CTs. So PET CT, we say it's a magic. PET CT means in a common man's thought, it is a cancer scan. Wherever I have a cancer, it will be finding it. It's not. PET CT has its limitations. So even with PET CT, when you say complete disappearance after giving systemic therapy, so if still we can see pathological disease at the site. You see how it lights up. We think every lesion, small lesion also it lights up. But we have limitation because of when you give systemic therapy, there will be tumor necrosis, there will be reduction in the average size. Suppose there is a 2 centimeter lesion which may become 1 centimeter, is difficult to find in PET CT. Decreased metabolic activity, that is because the chemotherapy is acting on the cells of cancer and they are no more going for that rate of mitosis which they are supposed to. Changes in the background tissue, what happens when you give more cycles of chemotherapy, there is changes in the liver. So that alters, changes in the liver means chemo related steatosis and the changes which will alter the enhancement of the background liver. So it, for a small lesion, it is difficult to find in that. So we look into the CT before chemotherapy, we had a lesion there, and the post chemotherapy, it has disappeared in the, particularly in the segment 2-3, and it reappears later when we follow the patient. So this is the MRI picture before giving chemotherapy. It is one of our patient here, and when you follow it, as you see, that has disappeared even with MRI. So what to do in this patient? So can intraoperative ultrasound add on to it? We have tried, and we saw with the present quality modalities of like radiology, what we have, the best of MRIs and CT, very few cases we are able to delineate more with intraoperative ultrasound. But this is a desperate attempt. Suppose we saw a particular region and we thought it will be there, and we have to do the primary resection also. We go to the liver, we are not able to locate it, we have no other choice but to do an intraoperative ultrasound. The people who are non-medical, suppose anybody is, the intraoperative ultrasound means you are directly going a ultrasound, putting an ultrasound probe on the liver and trying to find where the lesion is. So when you put on the abdomen, the localization, the delineation is difficult, whereas it is more easier when you put on the liver. So only 1.4%, this is one of the studies they have, you have additional finding which you couldn't find with a good quality MRI. So if you give contrast and do a contrast enhanced intraoperative ultrasound, it becomes further better. So what are the factors, if you can, which are the patient predicting which will be or which are likely to go for disappearing liver metastasis, where the metastasis may disappear. If you are giving a aggressive chemotherapy like a fulvestrant with irinotecan with cetuximab, then there is a significant chance that it may disappear. So what else? When the metastasis number are small and more in number, the chemotherapy cycles are more. It has been seen that in Corey et al., where like more than 5.5 cycles have been given, the chance of disappearance is more. So it happens whenever there is a, like suppose we have extensive systemic disease and you are going through a more number of chemotherapies, the chance of disappearance is high. Whenever you are giving arterial therapy, directly liver directed therapy, whenever you are giving or you have a synchronous disease, smaller lesions, and whenever the tumor marker becomes normal, this all increases the chances of disappearing liver metastasis. What are the confounding factors? Irinotecan and 5-fluorouracil, they themselves can cause steatosis and sinusoidal obstruction. So that changes the liver parenchyma and less contrast enhancement, and it is the decreased liver to lesion contrast, it affects our detection through the software, through our radiologist. So, when we say true complete response means there is pathologically when you resect, there is no microscopic disease in that. So, you see radiologically, you think it has disappeared, but true complete response means it also will replicate or will be found in the pathology. So, there is no absolute criteria whenever you say true complete response. It is from the studies we have found which are the patient where it is likely or more chance, not that they will have, the more chance that there will be true complete response. Like younger patient, smaller lesions and low initial CEA level, not the post treatment, and the BMI whenever it is like fit young patient like less than 30, and no detectable disease on MRI. This is post what I am telling. Initially all were pre and the last one is the post. If all criteria are there or more criteria are there in the patient, then there is a significant chance of disappearance of the liver metastasis, particularly the smaller regions. So, what are the treatment options? There is no clear recommendation what to do in this disappearing liver metastasis, because the evolution of the radiological imaging, evolution of the systemic therapy which are more effective now. So, the chance of true complete response is more, and the surgical technology with the AI, with the augmented reality has changed the management also. So, where to resect? What are the points in favor of resections? We saw the fewer patient in the data, present data, what is the best data available, that complete response is less than 20% of patient, means pathological complete response. And there is a higher recurrence. There are studies where they have done the number of like more than 400 cases on either arm, they have found that more chance of recurrence if it is left. Complete clearance is what is the point against surgery? Complete clearance is a challenge. Multiple lesions which have disappeared, which are close to the vessels, and we always have a fear of decreased future remnant liver, and particularly if you are doing a segmental or anatomical resection, and patient with bad molecular statistics. This disease is bad. So, this all goes against surgical resection, but still we do not have a clear recommendation and we still favor surgery. So, the other last one is surgery. When you do surgery for multiple lesions in liver, there is a surge of growth factors which may help the tumor to grow also. That is another point. And the blind dissection sometimes increases the morbidity without giving clearance, that is a fear. Here comes the fiducial markers. What is fiducial markers? It's like a boundary putting out the tumor, around the tumor. How to put? It is like radio opaque metallic pellets which are put around the tumor, and this helps particularly for smaller tumors, deeper tumors. So, whenever it is more than 10 millimeter deep in the liver, less than 20 millimeter size, outside the planned field of resection, suppose you are doing a left sided liver resection, and this is a lesion which is on the right side on the segment 8 deep in the liver parenchyma. So, these all lesions, if you put fiducial marker, it may help even if it disappears to locate the tumor. But this is a online survey which was done by Maelstrom et al. Well, they have found 1 out of 4 surgeons routinely place fiducial markers. That is very surprising, only 25%. So, what we understood is like smaller tumors, deeper tumors, scattered tumors are important where you need fiducial markers so that we can locate. So, this is the fiducial markers what we have seen and it have located. Even if you do not see the tumor, you see the fiducial markers. Particularly, we need the fiducial markers on the deeper extent of the tumor. So, 50% of surgeons indicated if they are not able to identify in that survey, they will leave the tumor and observe. That is more interesting. So they have tried intraop ultrasound, they have tried MRI before surgery, and if that is not delineating the tumor, they leave it and follow it. So what is the current evidence whatever we have seen, I am not putting all the articles. Patient having original sites of disease who have resected, they have reduced chance of intrahepatic recurrence. They may have systemic, but rather than leaving it in situ. However, even though the disease-free survival is better when you have resected, there is no level 1 evidence to tell that overall survival has become better whenever we have removed this. Other deciding factors, this all like for the patient side, patient performance status, comorbid illness, risking the surgery, tumor features like the tumor burden, localization and the mutational status. Sometimes the patient refuses. He has an understanding, a logical understanding. My tumor has disappeared, why should I go for surgery? Technical feasibility. Multiple tumors very closely deep inside near the vessels, so whether to operate or not. Chemotherapy holiday means whenever we have given chemotherapy, it has disappeared. Should we stop it for some time, the sequence of cycles, and see whether it is reappearing? That has been tried also, which is called as chemotherapy holiday. I weight criteria. I think many of you may be knowing that this is a criteria to find the difficulties, technical difficulties, the expertise need for difficult liver metastasectomy or liver tumors, mainly for robotic and laparoscopic resection. This includes the location of the tumor, the liver background, whether with a child A or child B patient, whether you are doing anatomical, which anatomical segmental resection. So these all leads, and the score is from 1 to 12. 1 to 3 means very low risk, and when it becomes more than 9, it is a high risk. So this has been tried to replicate in metastasectomy also. There are 7 different scenarios what you are seeing in the picture, and depending on the scenario, particularly the 1 to 3 scenarios are easier to remove, whereas the scenarios 6, 7, 5, 6, 7 are more difficult and need special expertise, and there you may hesitate to do a resection rather than doing a ablation or some form of other therapy other than surgery. Augmented reality. So augmented reality means where we use the data available with us, like an image, and do a 3D reconstruction and see how the location of the tumor, or we put it superimpose on the patient while operating and try to see where the tumor is. We see where the location of the tumor, how far it is from the vessel, am I close to the vessel now. These all are helped through augmented reality, and that helps increased R0 resection and patient where we have difficult location of the tumor. Artificial intelligence. So there are so many ways the artificial intelligence helps in, like automated image analysis. The radiologist may overlook it, but the data provided through artificial intelligence, it upgrades the software and automatically suspects the areas where there are likely to be tumors. So there are different, particularly by IBM, we have a special software which helps the liver tumors to be detected if it is overlooked. Predicting the treatment response. We provide the data, what chemotherapies we are giving, what is the patient status, all parameters we provide, and it predicts which are the patient likely to be going for disappearance of the liver metastasis. That helps to increase surveillance, more frequent surveillance on this patient, so that early detection of the liver disappearance and treat it. Personalized treatment and prognostication. These all held by artificial intelligence. So what is the end treatment? I have made it very simple. Treatment recommendation. MRI not only before, after neoadjuvant therapy. Selective fiducial markers placement before neoadjuvant, particularly deeper tumors, smaller tumors, and regular restaging after every 3 courses, which has shown rapid response. Suppose you found that it has response is rapid, then you have to every 3 courses of treatment you have to see when it is disappearing and to decide whether to resect at that moment. So resect or ablate the area considering always this microscopic, like I told, up to 60-70% there will be microscopic tissue at the area which you have resected. So resect it as far as possible rather than leaving it and expecting it to come back. Surgery is always better than the other forms of treatment. If possible, go for surgery and resect that area with a good margin. There are other newer modalities which helps, like Dr. Ellen told, like different like staged hepatectomy, portal vein embolization and liver partition. All those will help you to treat bilobar multiple liver metastasis, and there are other newer modalities also which are helping. If you are not able to locate difficult location, you are not sure of it, then you can opt for radiofrequency ablation or microscopic ablation, which sometimes it may be combined with surgery. Particularly like you have a left lateral segmental lesion and pure lesion on the right side. You can treat the right side deeper lesions with ablation, left side resection. This is the algorithm what we propose, like you go for a multidisciplinary evaluation for chemotherapy. See, and during the assessment, see whether this patient is a high risk for disappearance. Smaller tumors, deeper tumors, put fiducial markers, follow it, restage after chemotherapy, disappearance, then see whether patient is a candidate for surgical treatment at that moment with intraoperative ultrasound. If it has not disappeared, then you have to treat. If it has disappeared, attempt to treat the original site what you have seen, and that helps, and different forms of surgical treatment. Thank you.
Thank you, Dr. Swain. To conclude the surgical track, I would like to invite our next speaker, Dr. Balamurugan, Senior Consultant in Robotic and Hepatopancreaticobiliary Surgery. He is known for blending innovation with deep compassion. With over 15 years of excellence and over 20 publications, his vision is elevating outcomes in complex oncology cases.
So good afternoon everyone present here. So I thank Apollo Proton to giving me an opportunity to talk on this Apollo Liver Cancer Clinic. So here being a surgeon, hepatobiliary surgeon, here my talk is on laparoscopy and robotics. So beyond the scalpel, so what we have for the surgical treatment in liver cancer surgery. So surgical resection remains the cornerstone for the curative treatment in early HCC, and recent studies also have shown that previously unresectable, we have a lot of other options like portal vein embolization, and those who have uncomplicated portal hypertension, they may benefit from the liver resections. And there are a lot of neoadjuvant therapies right now for the liver cancer, which makes all the major resection into a minor surgery, which makes the post-operative outcome well. So lot of combination therapies are being used with targeted therapy, with the radiation, with the TARE and with TARE. We make most of the cases unresectable into resectable, and then we are operating. So on the BCLC staging, we have this resection for the hepatocellular carcinoma, is that only one indication is there. So for any early stage, when the lesion is single, and if it is less than 5 centimeter, we have this resection. But also we need to consider the other considerations, especially depends upon the tumor size, the involvement of the major vascular structures, and the patient's liver function and the performance status. All this decides before going for the surgical resection. So hepatic resection, it depends on the tumor size, location and hepatic reserve, and there is no strict guidelines like which size has to be operated. So even large tumors can be safely operated as long as we have a sufficient hepatic reserve. So only the main complication after resection is the hepatic failure and the recurrence. So these has to be taken care of for any surgical resections for the liver cancer. So types of liver resections, we have anatomical resection to go with the segments of the liver, and we have non-anatomical wedge resections, minor hepatectomies, major hepatectomies. The only goal is the clear surgical margin. That is alone will increase the disease-free survival. With the consideration, as I said, the margin negative resection, and if there is any consensus of which margin, is it 1 centimeter margin or 2 centimeter margin, it is been said like if it is more than 2 centimeter, always there is the recurrence is less. So this picture, it shows how the hepatectomy is being divided for the liver resections. This is with the segments. So we have right hepatectomy, we remove the entire right lobe of the liver, and extended we remove some part of the left lobe, especially 4A and 4B. And if in the left lateral segment we remove the 2-3 segments, and for the left hepatectomy we involve this 4. So when you do an open surgery, so usually the scar is this big, and the patient post-operatively they land up in respiratory because of the scar in the epigastric region. The respiration is always in the poor side on the post-operative because of the pain. So these patients may land up in longer hospital stays. So traditional challenges in this open surgery made us to go into the shift to the minimally invasive surgery. So minimally invasive surgery, they have the reduced blood loss, smaller incision, and lower complication rate, shorter hospital stay, and oncologically safe as well, and enhanced magnification with the minimally invasive cameras, and which increases the resection, and patient preferences is also there. They need more cosmosis and quicker return to work. So goal of this minimally invasive liver surgery is precision. We have to have an enhanced visualization with magnification and targeted dissection, and then safety is also needed because with the laparoscopic resection or the robotic resection, we have a reduced intraoperative blood bleeding and lower bile leak because of the enhanced magnified vision on the surface area after the cut surface. If we see any bile leak, it can be easily sutured in the immediate post-surgery and faster recovery. So evaluation of laparoscopic liver surgery, it started in 1990, where minor wedge resections were attempted in laparoscopy. It goes for the experimental phase. But during that period, it is limited with the gadgets. We don't have that much of harmonic or any gadgets to reduce the bleeding. So that time it was only this been with the minor wedge resections, and on the early 2000s, there was an increasing use of this laparoscopy for the liver resections. They were doing anatomical segmentectomies, improved instrumentation and energy devices started to come. And in 2010s, after that, there was an expanding indications for hepatectomy, where major hepatectomy were done in laparoscopically, and then in late after this, we had robotics into the scene, where robotic major hepatectomy, complex HPB resections were done because of the dexterity of the robot. So future is the AI guided planning and augmented reality, and increased adoption of miles is going to be there. And benefits, we know it's smaller incision, reduced blood loss, faster recovery, and lower postoperative complication. But there is limitations with this laparoscopic. So it has a steep learning curve, limited tactile feedback, and difficulty while during major resections. When you do in laparoscopy, when you have a major bleeding, there is difficulty there, always there to control the bleed with the laparoscopy. And patient selection is also crucial, because most of the hepatocellular carcinoma patients will have a associated liver failure, and they have multiple tumors. So these are all the consideration which are all the limitations for the indication for the laparoscopic liver surgery. and increased intraoperative bleeding control techniques. Then high equipment and setup is also there, because definitely you need a laparoscopic ultrasound for the laparoscopic liver resection, because for tumor localization and for the hepatic veins to guide the transaction of the liver there, this laparoscopic ultrasound is definitely needed. So with this limitation, yet we are able to do a lot of laparoscopic liver resections where even a huge right lobe liver is being operated laparoscopically. So where the liver is being compressing on the compressing on the IVC. In spite of that, see, you could see this is the right lobe of the liver, where the entire right lobe is involved by the tuber, and there is a partial involvement of the caudate lobe, where laparoscopic right hepatectomy was possible. So these are the ports, and this is small video. So it showed it started with cholecystectomy, and then with started with cholecystectomy, then hepatoduodenal dissections, where you could see the portal vein. So there the portal vein is visualized. Then you see the right hepatic artery. The branches of the right anterior, right posterior are clipped individually, and then it's cut using ligature. Once that is done, then the right portal vein is encircled. It's the right portal vein that is being encircled with the vessel loop. So it is been clamped with bulldog to see for the demarcation, and once you see the demarcation, it is being marked with the monopolar on the surface of the liver. Then initially we tried to mobilize the entire liver. So this is the, and since the tumor is so huge, the mobilization from the posterior is not possible. Then we transform the case into an anterior approach for the liver transaction. So this is the IVC that is being dissected. So these are all the individual short hepatic veins draining into the right lobe is being dissected, and this is the right inferior hepatic vein that's been encircled. So right inferior hepatic vein is encircled and clipped and cut. So now the Pringles maneuver is being made to run the right portal vein, which was clamped that time, is being clipped, and then the transaction is proceeded with the thunder beat. So that while during the transaction you have to go with the middle hepatic vein, and so there you could see the branches of the middle hepatic vein which are individually clipped and cut, which is draining the right lobe of the liver where the tumor is there. Now the caudate transaction is done well away from the IVC to make sure the patient had a negative margins, and these are all the individual short hepatic veins that are draining to the uncaudate veins that are being clipped and cut. And the guide is the middle hepatic vein, which is being used for the entire transaction. after the transaction is complete, the pending is the right hepatic vein, which is then clipped. So on the surface of the middle hepatic vein, the transaction is proceeded. And this is the transaction of the right hepatic duct using the vascular stapler, and then after that further transaction is proceeded over the IVC, and these are all the final things. So now the right hepatic vein is being transected using vascular stapler. After this, the entire tumor specimen is free. So this is the specimen. It's a huge tumor that has been done completely in laparoscopy. We get a good negative margin, and this is the scar. Post-operatively, the patient developed well, and it is almost 2 years now. And the beauty is this: he and mine are having the same date of birth. So he's been my friend right now. So then after that we went into this single port hepatectomies are being done for smaller minor resections, where the post-operative, the scar is very less, and you could see here. So this is the single port through which you have multiple ports in that, and you can introduce the camera. And through that you can go in and you do a left lateral segmentectomy through a small scar. So post-operatively patient recovers well, and you could see when you go, there is a left lateral segment that has been, segmentectomy is done. But even though we have this in laparoscopy, there is always a change. Change is the only constant. So now we have moved on to the robotics. So enter the robotics, a paradigm shift in the liver surgery because of the high 3D vision wrist instruments. It has 7 degree of motion and increased dexterity, and there is decrease in tremor for the surgeon also, and with superior ergonomics for the surgeon. So the core technology is we have 3D vision, the endo wrist, and enhanced ergonomics. So this is the parts of the Da Vinci Xi which we have. So how does it work? It's a simple video which shows that it has a boom and which is being shifted towards the patient, and then the instruments are introduced, and surgery is being done. So we have advanced technology in these robotics. We have robotic staplers, we have robotic vessel sealers which is used for liver transaction, we have robotic harmonic which is used for, and ICG. And other instruments also are in the armamentarium for this liver surgery. So this is how the OT setup is there for this robotic liver surgery, and this is a sample of how the robotic hepatectomy is being done. So application is, initially it was done for the minor liver resections, and now they have moved on to the major, and even now the indication has gone up to the liver transplantation for the robotics. So what is the advantage of this robotic is mainly when the tumor is near the major vessels, while you dissect, and if there is a bleeding, you can have this robotic instruments which does the stitching like how the open hand is being done for the vascular stitching. So those things can be done with these robotics. So it it also helps in these complex cases, especially for the post-chemotherapy patients, where ICG helps us to locate the tumors, where we can use with the ICG, limited tumorectomy alone can be done with a good margin of 1 centimeter. There, the post-operative liver failure is that rather than going for a major resection. In such cases, these robotics is definitely helpful, and especially for the deep-seated and centrally located and tumors. and even with the robotics for intraoperative cholangiocarcinoma, where the better lymphadenectomy improves the survival rate, where this robotics helps us to do a better lymphadenectomy rate. And oncologically, when you compare with robotics and laparoscopy, it's been said because of these advantages, their R0 rates are comparable with and sometimes superior to the laparoscopy. And because of the better visualization, it's an ICG, it shows the location of the tumor intraoperatively during a robotic surgery, where you can locate the tumor and do a resection of the tumor. So this is a picture which shows intraoperatively where you have, especially for the colorectal liver mets, you could see the location of the tumor intraoperatively with the ICG, and then you go ahead with the resection, which gives us the better margin for these tumors. So because of this, we have an improved patient outcomes, less postoperative pain, and faster recovery and shorter hospital stay. So when you compare this major hepatectomy in robotic and laparoscopic, so in robotic we have a lesser conversion to open than the laparoscopic, and but other factors are actually like comparable. So future direction is artificial intelligence, where it helps for the diagnostic as well as surgical planning, and ICG for the real-time tumor location, and 3D reconstruction also is there possible intraoperatively during the robotic surgery. So that has been visualized, and molecular profiling targeting therapies. These are all the future perspective for the liver surgery. And in summary, so we have surgical resection is the best option, and in which the minimally invasive surgery is definitely going to helpful for the patient. Thank you.
Thank you, Dr. Bala. We'll skip the Q&A session and dwell directly into the oncology track to explore innovations that are improving survival and quality of life. It's my pleasure to introduce my mentor, Dr. Ashu Abhishek, Senior Consultant and Lead GI Radiation Oncology at APCC. With 20 years of experience in oncology, has liver as special interest and has received multiple training and observationship in modern radiation techniques at reputed centers abroad.
Thank you, Anupama. So basically we have seen a lot of other specialities where it's important in how we treat with liver cancers. Radiation is also an important part of this armamentarium. What I am going to touch upon is how radiation is involved, and especially being at a Proton Center, which was the first in Southeast Asia in 2019. Proton is really there to evolve how radiation is being given to liver patients. So basically HCC is an issue because the presentation is different. There is large disease, multifocal disease, complicated by portal vein tumor thrombus, and that is how we have so many multiple modalities, and each and every modality is unique in its way, because there is individualization of a patient where one modality will fit in. Ultimately, we do understand that there's something known as a popcorn kernel effect. So you have a background of cirrhosis where every now and then new lesion will come up, and that is how transplant still remains the best choice. 5-year survival of more than 70%, but unfortunately only 20 to 25% patients undergo transplant, and most of the other patients are non-surgical. They have to be operated by local therapies. Now the issue with local therapies is to find out the right patient where there's only a single liver lesion where we can give liver-directed therapy and no new lesions will come up. That is the dilemma, and that's how it's not easy to decide which therapy will be the best for such cases. Now we all go by the BCLC, where we know that there are modalities like RFA, TACE. Radiation was never there, but in the last 2 decades, especially thanks to Dr. Laura Russell, who has been my mentor at PMH. So she was a key person who brought about radiation in perspective and how it can be used in liver cancers. And after that, now NCCN guidelines, Korean, Taiwan, everyone talks about radiation in a different way, how it can be used for liver cancer patients. Now, what is the issue with liver radiation? One, obviously, is the background of cirrhosis. There is a lot of issues related to radiation-induced liver damage. And then we are treating a tumor that is moving. For a radiation oncologist to treat a target that is moving all around and not have a gadget and a technology to deal with it, it is very difficult. And that is how our focus has always remained. Earlier, we thought that liver is one organ, we have to treat the whole organ, but then to give a very high ablative dose to the whole liver is not possible. And that is how partial liver radiation concept has changed the way we have looked at liver radiation. And then the modern gadgets in delivering this precise radiation, and most important has been the dose delivery by motion mitigation, that is respiratory motion management. So what this PMH guys found out was, in cases which are inoperable, the survival and local control rate was not good. SBRT brought about good local control rates and survival, because of which SBRT was implied in so many indications, operable for bridge therapies, borderline to downstage, and also inoperable case as replacement or as a rescue for patients who are not candidate for TACE, RFA or larger lesions. But there were few issues. In these patients who had very good response with SBRT, the local lesions were controlled, but almost 30% of the patients had liver deterioration. That was possible because of the low doses that was going to the surrounding areas. And that is how the concept of improving the RILD, that is radiation-induced liver damage, came in. Everything has helped. Improved liver imaging, functional liver assessment, motion management has been the key. You can either gate or track these tumors, or you can treat these patients in breath hold. And ultimately, you have modern technologies like SBRT and Proton, which helps us in precise dose delivery. So now with the established modality as SBRT, as I said, it can be definitely used as a bridge and downstaging for operable cases. In inoperable and complicated cases, especially portal vein tumor thrombus is one entity in HCC where radiation has really worked, because most of the other modalities like transplant is ruled out, RFA is not possible, and that's how radiation works. So we had our own share at our previous institutes where we established that SBRT is good for portal vein tumor thrombus. The transplant team from our previous institute at Medanta, they had published that 2,500 liver cases where 450 cases were HCC, which were actually transplanted, out of which 25 of them were actually post SBRT and TARE combination, and in them also transplant was feasible. What was very interesting is in patients who are having portal vein tumor thrombus, where we use combination of SBRT and TARE and they are not transplanted, where technically the guidelines say only sorafenib is an indication, not even a single 1 year survival was noted in sorafenib. While these patients of TARE and SBRT, the 1 year survival of 40 and 2 year survival of 17% was documented in this literature. So even if they are not undergoing transplant, addition of TARE, SBRT to PVT cases works. The same thing continued at my previous institute where we did combine SBRT with TARE, and the median OS of 13 months was at par with IMBRAVE, which is the bevacizumab study. So it's not that every patient, but selected patients will definitely improve and benefit from selected use of SBRT in combination or as a sole therapy. So now we are sitting at a Proton Center. What additional advantage Proton brings? So basically we are talking about technology. Breath hold management, imaging is something that can be added everywhere. But what Proton brings is a typical physical property of this heavy particle. We have a waterfall dose effect. That means a patient whom you treat with Proton, there is a sudden dose fall off. So practically we say that there is no exit dose. This is important in liver cancers because earlier we neglected the low doses. We thought that only the high and the intermediate doses are important, while now we know that low dose spill to the liver causes fibrosis, which results in almost 30% deterioration of Child-Pugh score after these patients are irradiated with simple photon, especially older techniques. With Proton, the general series suggests that there is only 3 to 9% deterioration of Child-Pugh score. This is the main advantage of Proton, which has been shown in comparative trials, where this is one of the unique areas where two techniques like photon and Proton have been compared in liver cases inoperable, and there is a survival benefit, all because you can save more liver and the deterioration of these patients post radiation is much lesser. This is also based on a concept known as fall-off volume. So basically if you are going to treat a target, in how much of an area your dose from maximum to reduces to 0. So this is the fall-off volume, and if you compare the existing modalities, so we know volumetric arc therapy and CyberKnife are the basic most high advanced photon therapies, and if you compare that with Proton, the fall-off volume is almost half in Protons, and that gives the benefit. Especially it is more pronounced in cases which are larger volume. This is more pronounced also in patients when they are Child-Pugh B, A7, B9, because these are the areas where patients who are having lower doses, the effect of IRLD is higher with low dose when your Child-Pugh score increases, and that is how the benefit of reducing low doses, which is achievable by Proton because of its physical dosimetry. The other problem and issue with photons is if you are having a normal structures around, generally you will give 90-95% of doses, but the areas that are close to the OAR, you will underdose. That is not a problem in Protons because of a better dosimetry. And that is how you achieve a better response rates whenever you are able to give protons, and that is how now proton is a category and indication whenever we talk about liver cancer treatment. And it's not only dosimetry. If you see the results where these patients have been transplanted, even the explant shows a good pathological CR after SBRT and also proton cases. It's not only individual studies, there are prospective studies, not only from Japan, which has clearly showed the comparison of photon and proton, not only in the routine cases, but also complicated PVDT cases. And even in bad CPB and C scores, proton is something that can be given, and it's a decent survival and local control rates. It's not only the East, even from West MGH, this is the landmark paper from Theodore Hong, which established how we take up proton for these cases, and now the 15 fraction protocol is the standard for all these large patients. Most of the patients who will require radiation, smaller tumors can be treated with photon, but the technical and challenging cases are especially larger ones, which are more than 5 centimeters large volume. Even in those cases, because they are able to achieve a higher BED and dose, the local control is much, much better than photons. And especially in challenging cases where you have less than 700 cc, 800 cc of normal liver, which is mandatory as a surgeon will think in terms of the functional liver volume. These patients also where photon is not possible, proton can be delivered and you achieve a good result. Obviously, if you have a modality, you need to have a comparison, and what better than to have a randomized control trial. So proton versus RF, definitely there is non-inferiority, and there is a trend towards better local control and PFS for protons. When you compare TACE with proton, definitely the OS is same, but if you compare the local control and PFS, it is definitely superior for proton. And I'm sure Dr. Jekan wants to hear the comparison between TARE and proton. That is not there, unfortunately, as of now. So it has to be individualized. But still, from these results now, proton is discussed in most of the guidelines. Even Astro talks about it. What are the typical cases which will benefit from protons? Large HCCs, portal vein tumor thrombus, poor liver function, baseline cirrhosis, complex anatomy, and definitely re-radiation, where proton will suffice and will be indicated even when normal photon is not possible for these cases. Something new which has come up in liver cancers is immunotherapy and target therapies, which was not talked about a decade before. So most of the trials where you see either it is STRIDE or IMBRAVE, the complete response rate is between 5 to 3% in most of the patients. But this was the latest 2024 paper where they combined radiation with IO, and the complete response rate was 46%, which is huge. So that is very phenomenal. And even in these patients who achieve complete response, be it IO alone or IO with radiation, these 3-year survival is almost 3 times better when you combine radiation with IO. So this is something unique which is now being tested and tried in prospective settings also. Now, what is our experience? So we have a prospective registry of ProLit, that is all patients of liver cancer that we treat with protons. So basically, small data, but 27 patients, most of them being HCC, cholangios also. Obviously, we by default won't select a child C patient, but most of them are either A6, B7. And basically, there are 2 ways we treat. Larger tumors, so generally the median volume being 300 cc, go for 15 fraction protocol. Smaller ones, 50 to 80 cc, generally will go for a 5 fraction protocol. This is something very unique and phenomenal. This is the last 13 patients post-proton and the fall in the AFP levels of these patients. The median fall of AFP for these patients is a tune of 80 to 90%, which is very good, very nice. And it also reflects in the radiological response for these patients. Most of these patients, as Dr. Jaikant also mentioned, initial first 6 weeks may be stable, but gradually if you can wait, and this obviously goes beyond saying that they have to be combined with systemic therapies, and if there's a good systemic control, you'll have a better local control also. Something unique about radiation is so many a times we have seen a patient of HCC referred to us for treatment, and then we do find some extrahepatic nodal disease. So the good thing in radiation is even that can be treated in the same setting, and then definitely they have good responses on evaluation. So just a brief, for our cases, there's been almost like 70% response rate when you compare the complete CR, partial and stable disease. Although our median survival is still not reached, 65% of them are still surviving. As I said, basically we follow 2 fractionations, 15 and 5 fractions depending on the size. And the local control rate is 60, almost 70% in these cases. And this is good in a way because it's a mixed bag where these are complicated cases not being able to treat outside. and then they come to us. It's not only radiation, it's a mix of systemic disease, extrahepatic disease later on, and still there's a good response. And if you compare our present data with the existing RTOG and SARA, I think it is very promising, although we are still early to say long-term results. But if you talk about the AFP drop, if you talk about the PVTT response, definitely radiation, the initial results are very good. Special mention about our 4 cases where we have treated proton with IO combination. So while the Pembro RT SBRT data suggests of a overall response rate of 36%, although it is only 4 patients, but our response is 75, which is very good. So just a mixed bag what we have treated. Most of our patients are old age, central, large, recurrent post RFA post test. In fact, this patient had a central lesion we treated, and this was the same patient where even Dr. Mukta came in and did the cryo. So this is how the multidisciplinary care helps. It's not only one modality that will help these patients. As these patients survive, as these patients are on follow-up, there might be individual requirements of different therapies in these cases. Most of our patients off proton will generally be large tumors where it is very difficult to achieve a good normal liver doses. While if you see in proton, if you are giving 50 gray to the target, this is the 5 gray dose, which is impractical to receive, get in a normal photon case. I'll show you an example. So we had this patient who had a very minimal 650 cc of normal liver, couldn't be treated on photon, was referred to us for proton, and when we did a comparative study, so this is the proton, this is the most commonly preferred CyberKnife for most of these liver cases, and this is a routine tomotherapy that we have. If you compare the dosimetry, the targets are almost same in all. The intermediate doses will be still comparable, but as you go with green and blue, these are unnecessarily areas that are irradiated on a normal photon treatment, which can really be spared in proton, and that is where the benefit of proton comes in for these patients. And if you see the mean dose liver, which we always will like to achieve as low as possible, proton has a huge benefit when you compare any modality of photons. Re-radiation, obviously proton is the first go-to treatment because it is very difficult to achieve normal liver doses in the first go, and if it is re-treatment, definitely proton is the modality. So one of a few cases which was post-transplant, had a large aortocaval disease, and a special request from the transplant surgeon was, please don't irradiate the transplanted liver, and that is how we can achieve this on a proton, which is again difficult to achieve on a photon case. So just quick words about cholangio. Not many cases, because most of the cholangios either should be operated or unfortunately they have extrahepatic disease, metastatic, they need chemo. But yes, inoperable cases from the same Hong study, we know that we can deliver much higher BED, and that is how proton is the treatment of choice for these inoperable cases. And from the same Hong study, what they found out, the median OS for these inoperable large cholangiocarcinomas was 22 months, which is better than the initial GEMSIS data, which was comparable to surgery and much, much better than routine SBRT that is offered to these patients. So one of our patients, 72 years post-chemotherapy, inoperable with a C2 MET, where we did give protons. Our first initial case, we gave 20 fractions and had a very good response after chemo. So take home says, HCC is a multimodality therapy. Obviously, surgery or transplant may be the first choice, but unfortunately, because of the general condition and non-transplant feasibility, the non-surgical therapies will be required. Radiation is one of them. Now, radiation something where IRLD was a concern, but now with modern technology, not only in terms of imaging, in terms of motion management, now we have in India techniques which the West was always proud of. So with proton coming in, definitely there are better patients, more patients that we can include in radiation. But it goes beyond saying that all these patients require a multidisciplinary care, where these patients have to be individualized and the sequence have to be decided in which way we treat. So thanks to our GI team, which has always been supportive, and also our radiation oncology team, beyond which we could not have completed this. Thank you.
Thank you, Dr. Ashu, for illustrating the power of proton therapy in liver malignancies. Now, Dr. Sujit brings us a medical oncologist's perspective on patient outcomes and quality of life in unresectable hepatocellular carcinoma. Dr. Sujit is our senior medical oncologist in the Department of Medical Oncology. He takes care of thoracic, abdominal, gastrointestinal, uro and BST groups.
Presentations are there. Presentation you can learn.
Maybe we could take up any questions meanwhile.
Thank you, Dr. Anupama. So, we have had from the morning, we have been hearing all the basics of liver cancers, including the hepatocellular carcinomas and cholangiocarcinomas. From the basics, we have had the radiology aspects, then we had the treatment aspects. Now, we'll come to the last session of this meeting, which is on improving overall survival and quality of life, maximizing patient outcomes in unresectable hepatocellular carcinoma. It's a sponsored session by Roche. So these are the different phase 3 trials. As you know, the use of immunotherapy and targeted therapy has revolutionized the treatment of hepatocellular carcinomas in the last 5 years. And not only in the last stages, or that this BCLC intermediate or high stage, C stage, we also have now use of immunotherapy in earlier stages as a bridge towards transplant. But in this talk, I will be mainly focusing on the use of immunotherapy in the advanced HCC, that is mainly the unresectable HCC. So as you can see, these are the different phase 3 trials in advanced HCC which has come. Initially, we had sorafenib with the SHARP trial followed by lenvatinib. And after that, the IM-BRAVE study came, which established the role of immunotherapy in hepatocellular carcinoma, especially the unresectable HCC. Thereafter, there have been multiple trials which could not find a positive result. Recently, in last year, we had Himalaya trial with durvalumab and tremelimumab, and Checkmate 9DW with nivolumab and ipilimumab, which are the combination IO protocols that have been approved for first-line treatment in advanced HCC. So how do we decide the treatment of choice? The treatment of choice depends upon whether there is an overall survival improvement, whether there is a good anti-tumor effect, whether the side effects are manageable, the quality of life is preserved, and also we also should know that many of the patients may progress after some time, and we should, as Dr. Ashu said, we should have an option of subsequent therapy in future. So these are the guidelines. We have been seeing it through all the day because we have, this is the way we manage unresectable HCC. Now for advanced HCC with portal invasion or with extrahepatic disease and with PS12, we have systemic treatment for unresectable HCC, especially the first line being the atezolizumab, bevacizumab. Apart from that, lenvatinib or sorafenib, especially if they cannot be affording that, and recently the double immuno combinations with durvalumab and tremelimumab. Apart from that, the ESMO guidelines also says about the same protocols as a combination of IO with VEGF inhibitor. The second line options, post sorafenib, we have regorafenib, cabozantinib, ramucirumab. Post immuno and targeted therapies, ideally we don't have much options, but we usually go back with oral targeted therapy when we have progression on first line immunotherapy and targeted therapy. Now, what are the treatment goals? As I mentioned, we have 2 goals. One is to improve the patient quality of life, to maintain the liver function so that we can have subsequent treatments. Also, as we know, the overall survival, the progression-free survival and response rates are also very important. So there has been different studies where, and there has been a review article which looked at what are the requirements for first-line systemic treatment. So there should be a wide benefit in terms of overall response and the progression-free survival, but also the treatment should be less toxic. So coming to the study design that IM-BRAVE 150 had utilized, the inclusion criteria include locally advanced and metastatic HCC, unresectable, more than one measurable lesion. The PS had to be 0 or 1, Child-Pugh class A, and no prior systemic therapy. Around 500 patients were randomized to a combination of atezolizumab and bevacizumab versus sorafenib. Now at that time, sorafenib was the drug of choice or the standard of care. Now you need to note that atezolizumab dose was 1,200 milligram every 3 weekly, and bevacizumab was 15 milligram per kilogram. Now there has been a recent study which has said, which has looked at the utilization of what dose of bevacizumab is being used in real world setting. Now, many of us in medical oncology do not go for 15 milligram per kilogram, not only for HCC, but also in colorectal cancers because of the toxicities. We have accelerated hypertension, higher bleeding risk. So now there has been a study which said that looking back at the response rates, at least the dose should be around 10.5 milligram per kilogram every 3 weeks. So we need to have at least 10 mg per kg of dose, although that's not the standard dose that was used in the design, but we should be careful that we are not reducing the dose of bevacizumab to less than 10.5 as per the study, which has a significant impact on what response had come. So there was different stratification based on the major vascular invasion, extrahepatic disease, and the AFP. So as you can see, they were well-matched trial, but one thing that has to be understood that because there is bevacizumab in our protocol, and we are definitely aware of the toxicities including esophageal bleeds that can happen in such patients, the trial did have around 25% of patients who had esophageal varices and also had high-risk patients who had extrahepatic disease or a vascular invasion. So as you can see, the high-risk patients are those patients who have either a vascular invasion or a VP4 or type involvement of portal veins, the tumor more than 50% of the liver. So around 20%, that's 1/5 of this patient patient profile had the high risk, and we'll see later what was the response rates. And it was well balanced between both the groups. Now, as you see the updated analysis of overall survival, which was presented in ASCO 2021 GI conference, as early as in 1 to 2 months, there has been a separation of curves, and you can see the separation of curves continues to happen till 1.5 years, and we have around 52% of patients surviving at 1.5 years when compared to 40%, which gives a hazard ratio of 0.6, and that is a significant thing, as you can see in the confidence interval. And the overall median survival was 19.2 months in the combination versus sorafenib, which was 13.4. Now, technically, practically, I would agree, there are students from medical oncology here. Sorafenib at the dose that we are supposed to give, 800 mg, is not very much tolerable. We have had patients who develop severe toxicity at 400, and we have to come down to 400, or most of the time they go only 400, which could be because of the baseline cirrhotic patients they have. But whereas the combination of IO with BEV or IO has its own toxicities because of immunological toxicities, but Atezo-Bev, for that matter, has been very easy to administer, and the tolerance has been very good in whatever experience I have. Sorafenib or lenvatinib, we do find very difficult to go for the full doses that has been advised as per the trials. Now again, the progression-free survival also had a distinct separation of the curves at 6 months and 12 months. Now coming to the updated response and duration of response, the overall response rates as per the partial response or the complete response is distinctly different when compared to sorafenib, which favors the arm of atezolizumab and bevacizumab. This is a subgroup analysis which actually analyzed the different groups which are involved in the trial. As you can see, there has been a lot of discussion happening regarding the etiology of HCC. We had an excellent class by Dr. Aditya regarding the etiology, and in India it is said that the non-alcoholic liver disease or the fatty liver associated HCC is going to be the most prominent factor, and it is the most prominent factor when compared to the Western world. There was a discussion, and there were still discussions going on whether the etiology of HCC can matter when we are choosing the treatment. To be frank, in my clinical practice, most of the time the decision is influenced by the financial status of the patient. Even though I work in Apollo Proton, that doesn't mean the patients are able to that they are able to afford. But coming up with the different companies have come up with patient assistance programs, which has made it much easy to afford. So the decision regarding the etiology does not much come into the picture when we have a discussion, but there is distinctly an improvement in the response rates and the survival when the etiology is viral. As you can see in the chart, in the forest plot, you can see the hepatitis C virus, the subgroup was doing much better when compared to the non-viral etiology. There has been post hoc analysis about this aspect, there has been analysis between the etiology and outcomes. Does it really matter? But as you see, it was not an analysis decided prior, but the post hoc analysis says that there is no significant difference between the proportion of patients who had response based on the etiology. So as you can see, the curves are all together. There is no much changes in the, or there is no much gap in the thing. So the author in this article had concluded that the etiology should not be the sole criteria where we are deciding that we should not be using atezolizumab, bevacizumab, or for that matter, any cancer immunotherapy. The same thing, as you can see, the overall response rates has been similar in non-viral population, in the HBV population and HCV population, irrespective of the etiology. The response rates have been better, and the progression-free survival has been distinctly different when compared to sorafenib. So same thing when you compare with the other trials where we have used immunotherapy, like the Himalaya trial or the Cosmic trial, there has not been much, there has been again a discussion happening whether the viral etiology or non-viral etiology influences the response rates. But again, there has not been clear pattern to say distinctly that we can exclude use of immunotherapy in patients who develop HCC in a non-viral etiology pattern. Now coming to the safety and the health-related quality of life, it has been seen, it was part of the study, and it was seen the quality of life is very good. Primarily, I would say it would be driven by the reason that the hand-foot syndrome is much less in this protocol, and that is my clinical experience also. We have there is a lot of mucositis and hand-foot syndrome when we have sorafenib or lenvatinib. I think it's more related to the Indian population rather than anything else. And in case of atezolizumab, bevacizumab, we have seen that hypertension is definitely there. Liver enzymes have to be monitored. We may have to add liver protective drugs as we are continuing the treatment, and we have to monitor for proteinuria. The bleeding, I don't use usually 15 mg per kg. I use 10 mg per kg as the dose, and I have not seen much of bleeding risk happening because of the combination. So again, we can see that this is a multi-trial comparison. The comparison between atezolizumab, bevacizumab versus nivo-EP, which is a double immunocombination, and STRIDE, which has been the study based on the combination of durvalumab. You can see that the suppression is much early in atezolizumab, bevacizumab, although it may not have much impact, but we can see that the risk of early progression or risk of having less improvement in the early months is less when you are using this combination. Having said that, this may not make a big difference in the treatment protocol. As I said, it may not decide what treatment we are going to decide. So again, this is again a summary of the overall survival results. We can see the hazard ratio has been nearly around 0.67 to 0.75 in many of these trials, and it is a comparison between different combinations of immunotherapy, bevacizumab versus sorafenib versus the other combination like cabozantinib, atezolizumab, and we can see that there is a good overall survival hazard ratio in atezolizumab with bevacizumab when compared to other. Again, we cannot cross compare the trial, but it's a meta-analysis and it looks in favor to the combination. Again, we'll skip this. There has been good response rates, and I think as we know, we all know, if we can see a good AFP response in 3 months and 6 months, they are the patients who go on to do well, and even many times they continue to do well even in the second line treatment when there is progression. That has been seen consistently in other immunotherapies also. So here we have the waterfall plot showing the difference between the response rates and the duration and the measure of depth of response. As you can see, the mean response is much better when compared to sorafenib. So again, the duration of response is very important in terms of immunotherapy and in terms of any cancer. The duration of response is very important. We have fascinating responses with the chemotherapy in many cancers, but we find that as soon as we stop the treatment and they come for follow-up, they have relapsed. So one good thing about immunotherapy in most of the cancers is that if there is a response, we see there is continued response, and many of them are long-term responders. The same thing is depicted in this graph, which says that when compared to sorafenib, there is much more response which are prolonged in case of the combination. So as we have been discussing, we need to have high response rate, deep response and long response, and that is true not only for HCC but for other cancers also. And again, when we had discussed, Dr. Ashu had discussed about the portal vein thrombosis. Again, when we have an extensive portal vein thrombosis, they don't do well when compared to a disease which doesn't have portal vein thrombosis. But here again, in the subgroup analysis, we see that irrespective of the portal vein involvement, the combination, we had patients, as Dr. Ashu said, we have had patients whom have come with a portal vein thrombosis, got radiation and went on to receive immunotherapy, and they have done well compared to the patients who have not got radiation before getting the immunotherapy. So then the next thing which we always have a discussion, as you all know, when a patient comes to us for a advanced hepatocellular carcinoma, most of them have a history of cirrhosis, and most of them are referred by hepatologist after a prolonged duration of cirrhosis and decompensated liver disease. So as Dr. Aditya had mentioned, they need to undergo a proper liver function assessment. Apart from that, mandatorily we should have a upper GI endoscopy as part of the workup. And there is the discussion always happens that if there is a varices, so how do we manage? So definitely bevacizumab has a higher risk of bleed anywhere, wherever there is an ulcer or wherever there has been a history of surgery and there has been a fistula. We are worried when we are using bevacizumab. But again, post trial there has been analysis whether it has it really impacted the use and the benefit of atezolizumab bev. So these studies shows that irrespective of the presence of esophageal varices, the use has not impacted the response, whereas we have to be very careful. We have to see what is the history of bleed. If the bleed has been there within 6 months of this visit to the oncologist, we have to be careful. If the bleed has not been well taken care with a esophageal varicose banding, we have to be careful. If you see the bleeding episodes that had happened in this study, most of them were epistaxis, and the bleeds that had happened from the esophageal varices or GI hemorrhage has not been very high. It was around 5% total, and the grade 3, grade 4 is around 3%. So it has, the bleeding risk is definitely there. We have to be aware. We have to take the precautions. We have to get a banding done. But if this were grade 1, grade 2, we can still go ahead with the combination, provided the patient is also on beta blockers to prevent a bleed. So this is the guideline that has come regarding such situations. So whenever there is a history of recent GI bleed within 6 months and a high risk of bleed, then definitely we should not consider this combination. But when they have been adequately treated, they may be taken up for this combination. Otherwise, they are the best patients for double immuno or IO combination. Whereas in case of varices which have been treated well with banding and who are on beta blockers and they don't have bleeding grade 3 esophageal varices, we can still consider to use this combination. It's always important to give a waiting period of at least 3 weeks. Usually we wait for 3 weeks, we confirm again with the CBC and with the stool occult blood, and we see that patients are stable before we consider for starting this combination. So coming to the treatment goals by stage, we have discussed it, especially in the intermediate and in the early phases. We have options of TACE, we have TARE, we have resection ablation and liver transplant apart from the liver directed surgery. But in case of advanced cases, especially, now there are trials, there have been trials where immunotherapy has been used as bridge towards transplant, as bridge towards proton therapy or SBRT. So in case of patients who are unsuitable for TACE, and they can directly go for systemic treatment, but the combination of TACE and systemic treatment also is very useful in debulking the disease, in bringing the disease, especially the local disease, if they are very large volume disease, they respond well with a liver directed treatment followed by systemic treatment. And in case of advanced BCLC stage C, if the patient has at least, definitely if child POC-A, and if it is even in B6, up to B6, we do consider use of immunotherapy and bevacizumab as combination, provided, as I discussed, the affordability has to be seen, the fitness has to be seen. So they are the first line of treatment, either atezolizumab, bevacizumab, or the IO combination are considered first line systemic treatment, or followed by lenvatinib, sorafenib. If they are not able to afford, we may have to use it first line. So again, the patient reported outcomes were better. Now, this is one thing which we see, the albumin and bilirubin scores. If there was again an analysis of this trial based on the level of albumin and bilirubin, which is indirectly and directly related to the liver synthetic functions and the liver excretory function. So yes, you can see the improvement in albumin bilirubin scores in the atezolizumab bevacizumab arm has been better. I would say sorafenib causes mucositis. It leads on to nutritional issues. In my experience, we have to reduce the dose many times. So maybe that also contributes to the albumin levels. So again, this is one of the things that we should consider, that the tolerance is much better. And again, subsequent therapy rates are better with this combination when compared to other treatments. And these are the real world data, 5-year survival data from Taiwan. As you can see, there are 5-year survival of 20% in advanced unresectable liver cancers, which is very good when compared to what standard of care we had earlier. So to conclude, atezolizumab bevacizumab does continue to have a consistent, meaningful treatment benefit versus sorafenib. The median survival is 19 months when compared to 13 months. The progression-free survival also is better with a good hazard ratio. The response rates are good. In our experience, if the patient is fit for the treatment and can afford, it is much tolerable. We have patients who cross 1 year, 2 year on this treatment without much of toxicity. And in controlled esophageal varices, that is very important, they can be considered safe for use. Now we have this as a standard of care based on this trial, and we have long-term data now, which was the first, it was the first combination to be approved. Now we have also options of IO in patients who cannot be considered fit for this combination. And as I said, we are, as all our speakers said, we are looking not in terms of waiting for them to become child C. We are looking in terms of integrating immunotherapy in a neoadjuvant or like a bridge to transplant, or post-treatment as a maintenance to prevent that ultimate liver decompensation and death. Thank you so much for patient listening.
Thank you, Dr. Sujit. With this, we come to the end of our academic sessions. I request Dr. Asha Abhishek to give his concluding remarks.
So I know I'm standing between you and the lunch, but it goes immaterial to say that thanks a lot to all of you who have assembled here. It was a vision that we had almost 1.5 years, lot of planning. And special thanks to Dr. Sujit to have called Mr. Thiagarajan, because he is a gem of a person, the best person to have him on this launch. His book launch as a memoir of hope and courage was something that we look forward to our liver cancer clinic. This is what we want to replicate in our setting. A big thanks to Karan, who has been supportive to all our ideas, and Dr. Jalali, everyone. A big thanks also to speakers, because even if you see the topics, they are curated, they are so important that are daily challenges in our life. And each and everyone did their right part to discuss the intricacies of liver cancer management. A big thanks to even people, senior consultant and faculty, not only from GI but non-GI specialty, be it Dr. Sapna, Dr. Srinivas, Dr. Hedne, head and neck team, all sarcoma, prostate, because that is what we are looking forward. It's not about a GI liver cancer management, it is about everything that goes to liver, and that's how the whole APCC team as such, we are thank you for you being part, and probably will need your inputs future to go on forward with this liver clinic. A special thanks to our junior staff, Dr. Anupama, Dr. Safa, who has been supportive. Thanks to our IT team, thanks to our media, our housekeeping, and a big thanks to Roche also, because they have been very supportive to actually bring out this conference, which was successful. With this, I'd like to invite you for lunch, and please, I'd like to invite our GI CMT to have a group photograph, please. Sir, come. Come, Dr. Prashant. Call her also. Call her also. Dr. L.
Dr. Mukta is left. Dr. Vimala, come. Prashant. Lunch will be served in the 8th floor. We have a rooftop cafeteria. All are welcome for that. Thank you so much for attending this meeting.